hurmatli mehmonlar, iltimos joylashinglar, hamma o'zini joyiga o'tirsin. Доброе утро, уважаемые гости. Пожалуйста, присаживайтесь. Уже больше времени прошло для старта. Так как формат конференции на английском, основные доклады будут на английском. У кого будут возникать вопросы, пожалуйста, можете задавать после докладов. И начало выступления все запланировано сделать на английском. Hello everyone, we're glad to see you all here in Tashkent in our spinal stethoscopic surgery conference, USMIS 2023. It is a big event for us. The program is shaped in a way to attract your interest and exchange ideas with the professionals around the world. We put a lot of passion in shaping a conference that will hopefully benefit all of us. We hope that enjoy these 2 days with us. And for the beginning, I am honored to invite our chairman of the conference, Dr. Kantaek Lim from Korea, to give us the welcome note. Please, Dr. Lim. This mic is working.
Good morning, everyone. As so happy and proud to host this big conference about endoscopic surgery in the Tashkent, in historic place in Tashkent. Thank you so much. You are attending despite your busy and hectic schedule. Unfortunately, some speakers don't make it due to the visa process. Anyway, I think it's this conference will be a good opportunity to exchange the academic information about the endoscopic surgery, and for beginner, it's a good chance to learn the endoscopic surgery. I hope you have fun and have a good time. So I think we can change the paradigm of spine operation in the world with endoscopic surgery. Thank you so much, and you have a fun and the good time today. Thank you.
Thank you, Dr. Lim. So next one, now I am pleased to invite Dr. Murajan Erismetov, the director of the head of the Department of Travmatology and Orthopedics at the Republican Scientific and Practical Medical Center of Travmatology and Orthopedics. Please welcome.
Assalomu alaykum, hurmatli hamkasblar, hurmatli anjuman ishtirokchilari, mehmonlar. Avvalambor sizlarni bugungi shu spinal stethoscopic surgery Tashkent 223 o'tishi munosabat bilan tabriklayman va shuni aytib o'tmoqchimanki, bugun
Dear guests, dear participants, I would like to welcome you all in this spinal stethoscopic surgery conference in Tashkent 2023.
Shuni aytib o'tmoqchimanki, bu anjumanni o'tkazilishiga bir nechta sabablar bor. Men shaxsan o'zim Kantaek Lim bilan 2018-yildan beri tanishman.
There are several reasons to make this conference today, because I personally know the Dr. Kantaek Lim from 2018.
Va bu professor va bugungi shu davrada ishtirok etayotgan bir qancha bizning hamkasblar va olimlar tufayli bizning yurtimizda shu umurtqa jarrohligi endoskopik yo'l bilan rivojlanishi yo'lga qo'yildi.
With the help of the Dr. Lim and several other spinal surgeons, this spinal endoscopic surgeries was started in our country.
Kentek Lim tomonidan qilingan bir nechta muvaffaqiyatli operatsiyalar tufayli bizning yurtimizdagi o'sha bemorlar hozirgi kunda juda ham baxtiyor o'zini hayotini davom ettiryapti.
And those patients who was operated by Dr. Lim in the beginning, they're all very happy and feel healthy for now.
Men bu sohani rivojlanishiga bir nechta sabablar bor deb aytib o'tdim. Hozir yana bu sabablardan bittasi hozirgi kunda bizani davlatimiz tomonidan, shaxsan prezidentimiz tomonidan berilayotgan e'tibor va ajratilayotgan juda katta mablag' tufayli oxirgi 5-6 yilda bu soha ham juda tez rivojlana boshladi.
Minimal invasive surgeries was acknowledged by our president also. So now, last 5 years, we have very good funding to develop this kind of surgeries in our country.
Va yurtimiz rahbariyati tomonidan ajratilayotgan yoshlarga bo'lgan e'tibor tufayli bugungi kunda mana shu Shomansur Shohaydarovichga o'xshagan yoshlarimiz yetishib chiqmoqda.
And with the help of our government and paying attention to the scientific knowledge of the young generation, now more and more young surgeons are growing very well.
Men sizlarni shu taklif qilmoqchi edimki, bizani markazga borib hozirgi kundagi sharoitlar bilan tanishish, chunki davlatimiz tomonidan ajratilgan e'tibor tufayli hozirgi kunda markazdagi holat, umuman operatsiya xonalari rivojlangan davlatlar o'sha kasalxonalaridan hech ham qolishmaydi.
And I would like to invite you all to our Orthopedic and Trauma Center to see the facility and our orthopedic operating rooms and all the opportunities which was created in our hospital as well.
Albatta tashrif buyuringlar, chunki O'zbekiston bo'yicha sizlarning o'sha taassurotinglar yana ham o'zgarishini men ishonchim komil va bugungi shu anjumanda sizlarga hammanglarga muvaffaqiyat tilab qolaman. Men o'ylaymanki, bugungi olgan bilimimiz keyingi ishlarimizda o'zini natijasini ko'rsatadi albatta va hammaga omad tilab qolaman.
I really want you to visit our country, our hospital, and you will have very good impression of our country. And the knowledge today we get from this conference, I hope it will give very good results in near future. So, thank you everyone for visiting this conference.
Thank you very much.
And let me invite our next honorable Dr. Shohada Shotusunov, Head of Vertebrology Department at the Republican Scientific and Practical Medical Center of Travmatology and Orthopedics of Uzbekistan, to give a welcome speech, please.
Morning, welcome in Tashkent. Я буду на русском языке говорить, немножко побольше, чтобы ознакомить вас с состоянием, перспективами вертебрологической службы, вертебральной хирургии на сегодняшний день в Узбекистане.
I would like to speak in Russian language, and I would like to introduce and give you some short information about the situation of spinal surgery in Uzbekistan.
Уважаемые гости, уважаемые друзья, уважаемые коллеги, дорогие участники нашей конференции по спинальной эндоскопической хирургии, позвольте выразить вам свою благодарность за участие в нашей конференции. Также я хочу поблагодарить председателя конференции доктора Лима за активное участие в организации этой конференции.
Dear guests, dear participants, I would like to give my gratitude to you all for the participation in this conference. Especially, I would like to say thanks to Dr. Kantak Lim, chairman of this conference, for helping organize this event today.
Также членов оргкомитета, руководство сотрудников клиники ProfMedService за прекрасную организацию нашего форума.
Also the hospital ProfMedService and their staff members to helping this for organization of this event.
Также всех наших спонсоров, компания Медицинский, Максмод, Ривоспайн, представители, которые здесь находятся, которые внедряют новые технологии и активно участвуют в наших службе по вертебральной хирургии.
Also, I would like to say big thanks to our sponsors of this event, the company Medicei, Max More, Rivospine, and B. Brown.
Место проведения этой конференции, наш город Ташкент, выбрано не случайно. За последние 20-25 лет вертебральная хирургия в Узбекистане бурно развивается. С 90-го года у нас в стране организовано несколько крупных клиник по вертебральной хирургии. Не только в Ташкенте, и даже в областях, в Андижане, Самарканде, представители, которые здесь сидят. И наши коллеги подготовлены достаточно кадров, потенциал высококвалифицированных кадров, которые активно занимаются в развитии вертебральной хирургии в Узбекистане.
The event is in Tashkent, Uzbekistan, holding in Tashkent, Uzbekistan. It's because last 25 years the spinal surgery of our country is developing very actively. So now for today in Tashkent we have several spinal surgery centers in Tashkent, and also in other cities like Andijan, Samarkand and Bukhara we have opened several hospitals which is specialized in spinal surgery.
У нас внедрены почти все современные высокотехнологические способы оперативного лечения повреждений заболеваний позвоночника, и особенно последний год это способы малоинвазивной хирургии позвоночника.
We have started doing all kind of surgeries on the spine, the open surgeries, the minimal invasive surgeries, and the last 4-5 years the spinal minimal invasive spinal surgeries is developing very well.
Мы считаем, что достижение такого уровня вертебральной хирургии Узбекистана мы обязаны многим нашим друзьям, учителям, партнерам из крупных зарубежных стран. Особенно мы очень благодарим наших учителей, Харьковский центр травматологии-ортопедии, Харьковский центр патологии позвоночных суставов, представитель которого профессор Радченко и Пьянковский здесь находится. Спасибо вам за участие в нашей конференции. Также мы активно работаем с российскими нашими специалистами. Значит, есть школа Георгия Степановича Юмашева, Сеченовский институт, представителей, ученики профессор Худобердиев, профессор Абдухаликов здесь находится. Также мы активно работаем с белорусским центром, с доктором Макаревичем Сергеем Валентиновичем. К сожалению, он не смог присутствовать сегодня. Мы активно работаем с Новосибирским центром, Российским центром вертебрологии. Профессор Александр Евгений Симонович, наш близкий друг, мы с ним давно активно работаем. Также вот Московская школа спинальной хирургии, Петербургская школа спинальной хирургии, доктор Пташников, доктор Усиков, с которыми мы активно работаем.
To reach this level of the spinal surgery, we would like to thank all international hospitals which helped us to develop our spinal surgery to this level. First of all, it's Ukrainian friends from Kharkov University is Professor Radchenko and Dr. Piantkovsky, who is participating in this event. Also the Russian hospitals, the school of the Professor Yumashev in Russian Federation, and also we working with the Belarusian and our international hospital friends.
Особенно такое бурное развитие вертебральной хирургии у нас началось после вступления Узбекистана в Международную организацию по минимальной инвазивной спинальной хирургии ИСМИС. Под патронажем, под руководством профессора Радченко Узбекистан в 2012 году был принят заседанием президиума в состав ИСМИС, Международного общества спинальной хирургии, штаб-квартира, которая находится в городе Цюрих. Там было заседание президиума, где профессор Радченко выступал за Узбекистан. Он гарантировал, что в Узбекистане будет развиваться спинальная хирургия, и сегодняшнее наше состояние – доказательство гарантии профессора Радченко, что в Узбекистане минимально инвазивная хирургия активно развивается. Под эгидой
The spinal endoscopic surgery, the spinal minimal invasive surgery was first started developing from 2000 in our country from 2012 when the Uzbekistan has joined the ISMIS organization with the help of the Professor Radchenko in 2012. Yeah, the ISMIS is international organization who is which is headquarters is located in the Zurich.
Под эгидой ИСМИС мы уже активно начали работать с 2012 года с нашими коллегами из Швейцарии. Президент ИСМИСа, доктор Ханс Юрглой, он был в Ташкенте, и он вел нас ИСМИС по рекомендации профессора Радченко, и мы с швейцарскими хирургами, германскими хирургами, профессором Томасом Люберсом, Руитином, турецкие наши коллеги, ИСМИС Турки, профессор Мехмед Залели, Хаяти Айгун, Али Фахр Узер, с кем мы хорошо работаем. Кроме того, наш близкий друг, председатель ИСМИС Индонезия и Североамериканского общества спинальной хирургии, доктор Бамбанг Дарвоно, он, который здесь присутствует, с доктором Бамбанг Дарвоно мы активно работаем по направлению сочетания, значит, ИСМИС Индонезия и North American Spine Surgery, конференции которых проводятся традиционно в Индонезии. Доктор Бамбанг Дарвоно имеет большой курс, кадавер-курс по малоинвазивной спинальной хирургии, где обучались многие наши молодые специалисты. Благодарим профессора Бамбанг Дарвоно за развитие вертебральной хирургии в Узбекистане.
From 2012, we also have good collaboration with the Turkmis organization, our Turkish spinal surgeons, friends, Dr. Mehmet Zeleli, and also from other international delegates, which we are very grateful, is Dr. Bambang Darwono, who is in Indonesian Society of Minimal Invasive Surgery. Our young surgeons have been in cadaver workshop in Bambang Darwono's educational courses.
Thank you. Кроме того, мы активно работаем с такими центрами, как ИСМИС Japan, профессором Акира Деваза и профессором Хидихата, французскими вертебральными хирургами, доктор Гастамбиди, доктор Жак Дестандо, которые здесь были, итальянские врачи, доктор Фонтанелло и другие многие ведущие спинальные хирурги, с которыми мы на сегодняшний день активно сотрудничаем.
Also the other international our friends who is helping for developing this spinal surgery is from the Italy, Dr. Fontanella, and from Japan, the Akira Dezawa and Fujo Ito.
И особенно я хочу сказать, новым этапом с 2015 года насчет корейской спинальной хирургии, мы начали активно сотрудничать с доктором Лимом из Сеула, который является председателем сегодняшней конференции, под эгидой, под воздействием и под финансовой поддержкой частной клиники ProfMedService под руководством доктора Умара Варашана. Мы начали активно работать с доктором Лимом из Южной Кореи с 2015 года.
From 2015, we have started actively working with Dr. Kang Tak Lim for developing the spinal endoscopic surgery in our country with the help of the private hospital, the ProfMedService, and its owner, Dr. Ravshan Umarov.
Как вы знаете, доктор Кang Tak Lim имеет свою частную клинику, где он имеет обучающий курс по спинальной эндоскопической хирургии по своей собственной методике, это PCLD.
As you know, Dr. Lam has developed his own technique, which is called PSLD, and he's actively educating the young generation for this method.
Через эту школу, через школу, обучающую школу, курсы «Контакт» доктора Лима проходили многие наши молодые креативные специалисты, многие, которые здесь находятся.
Many of our young surgeons have been educated by Dr. Lim in his hospital for this PSLD method, who is participating in this conference.
Обучение целой плеяды наших молодых хирургов по спинальной эндоскопии позволило нам на сегодняшний день организовать многие такие оперативные вмешательства на позвоночнике по малоинвазивной хирургии.
This educational program, which was our young surgeons educated, is helped to develop the spinal stethoscopic surgery in our country.
Да. И на сегодняшний день в многих клиниках Узбекистана проводятся спинальные эндоскопические операции. В месяц проводится более 100 операций по спинальной эндоскопической хирургии по всей республике. И эти клиники оснащены самыми последними технологиями, оборудованием по проведению спинальных эндоскопических операций.
And with these young surgeons per month doing more than 100 surgeries now in all around the country. So these hospitals are very well equipped with the last medical instrumentation and equipment.
И научно-практический потенциал Узбекистана, кадровый потенциал Узбекистана, молодые кадры позволяет нам на сегодняшний день создать общество малоинвазивной спинальной хирургии Узбекистана. И я считаю, что сегодняшняя наша конференция является учредительным в какой-то степени для создания узбекского общества малоинвазивной спинальной хирургии УЗМИС.
This human potential, the several young surgeons who was educated by Dr. Lim is now developing the spinal surgery in our country. So we can truly say that Dr. Lim has established his school of spinal endoscopic surgeons in our country.
Я считаю, я надеюсь, что наша конференция позволит всех нас объединить, многих наших гостей, Индия, Таиланд, Юго-Восточная Азия, Корея, Япония, Индонезия и других наших СНГ специалистов из Украины, наших учителей из России, из Белоруссии. И эта конференция, результат этой конференции послужит толчком для дальнейшего развития малоинвазивной спинальной хирургии в Узбекистане. И наше дальнейшее сотрудничество приведет плоды, как наш директор сказал, для развития, для оказания высококвалифицированной медицинской спинальной помощи нашим больным Узбекистана.
As a result of this event, I really hope that our scientific bonds with international guests and delegates and participants will help develop the spinal endoscopic surgery in the further steps in our country.
Еще раз хочу поблагодарить от имени узбекских спинальных вертебральных хирургов за организацию, за проведение этой конференции. Доктору Лиму.
And once again, I want to say thank you to Dr. Lim for of the names of spinal surgeons of Uzbekistan to help to organize this event, great event.
Да. Наша конференция будет являться новым этапом для развития нашего сотрудничества в области эндоскопической спинальной хирургии.
And I hope this conference will be the new step for developing the spinal stethoscopic surgery and our relations for future.
Желаю успехов в проведении работы этой конференции. Спасибо всем
большое. Wish you all the
большое.
best. Yeah, thank you. Okay, thank you everyone. And from this step, I am giving the moderation to Dr. Elmer Jose Merceda, Dr. Ejam, to start this first session. Yeah. Thank you.
Thank you very much, Dr. Shamansur. I will be moderating the opening session or the first session for the didactics. I would like to welcome everyone as well to this historical event. It's the first stethoscopic surgery conference in Uzbekistan and in Central Asia. There is going to be an expansion of endoscopic spine surgery in Central Asia and Middle Asia, and the patients, your countrymen, will be asking for endoscopic spine surgery. They will demand. The demand for endoscopic spine surgery worldwide is getting higher and higher. The patients are the ones asking for it. Today is going to be a busy day. You saw the program. It's going to be a very hectic 10 minutes each speaker, but we will not provide time for question and answer. However, during the breaks, you can reach and go to the speakers and ask them your questions if you have any questions. So we'll just move on with the speakers one by one. And then for the language of the speakers during the lecture, it will be appreciated that it's be done in English, but if you're comfortable with any language that you want to use, then please do so. And our first, I would like to call on Dr. Lim Kang Tek to tell us about the concept of stethoscopic surgery and the philosophy of spinal stethoscopic surgery. Dr. Lim.
Good morning again. I'll talk about the philosophy about stethoscope surgery shortly. Looking at the history of the operations, in Korea, the spine neurosurgeon tried the endoscope surgery in 2000, the early 2000. So at that time, there was the PL, right, transferal approach, inside out, outside technique. In Korea, it has the popular inside out technique. But I like the outside technique as Dr. Hoogland, as the CEO of the Yap Hoogland, his father. So its concept is very nice compared to the inside out technique, because when you approach the inside out technique, you have to sacrifice the annulus too much, and we have to remove too much the disc. So at end of the 3% later, we can see the collapse of disc height. So when I performing the endoscope surgery in the early 2000, so I thought always it's an incomplete operation, because in Korea we are the rapidly becoming aging society, so many patients have the disc and the stenosis combined. So with the transplant approach, just the full discectomy, but most patients has stenosis and the disc. So we had to develop a new concept of endoscope to solve the problem, the stenosis and the disc. So from the 2016, we had to we could make the manufacture new endoscope system with the Maximal and company. It's the stethoscope. So we can do now we can do from the C1 to lesion to the ACDF, endoscope ACDF, and the fusion surgery. But the philosophy of endoscope surgery can be, we can reduce, we can avoid the fusion surgery. So actually in Korea, the total case of the fusion surgery include the HDF or lumbar fusion has been decreased, because with the endoscope surgery we can do performing the decompression without any fusion surgery. That's why most of the patient want to get the endoscope surgery. Right? It's a new concept of and a new philosophy of endoscope surgery. The first time Dr. Kandimov here visited my hospital to run the endoscope surgery, and then thanks for especially thanks for Professor Shatter Shunov visited my hospital to see observe the endoscope surgery, and then I came here to teach the spine surgeon. So I think you are the pioneer who will change the paradigm of spine, the concept, right? So and it's the expert. You can expert the best surgeon in the world from India and Mongolia and Indonesia, right? And Taiwan and Thailand, right? They are the expert now. And I feel as we have the responsibility to teach young surgeons. It's a good chance. It's not working. Okay, it's okay. Okay, so I think it's a good chance to teach the young surgeon. That anyone who wants to learn the endoscope surgery visit my workplace, and I will visit again more and more. And especially thank you for the CEO of ProfMedService, Dr. Laoshan. He will organize this conference again. And this September, new hospital, the spine center, in 7th floor building will complete. So we can give an opportunity who want to learn the endoscope surgery in here. Okay. Anyway, I hope you have fun and great the opportunity. Have a good time today. Thank you.
Thank you. Thank you, Dr. Lim Kantek. Stenoscopy, or you can see the title of our conference is Spinal Stenoscopic Surgery. Stenoscopy is a term coined by Dr. Im in 2015. It's just like arthroscopy, coined in the 1940s. So it's a new word, and from 2015 we have been trying to promote the term stenoscopy as stenosis surgery for the whole spine, from the cervical up to the lumbosacral junction. For the next speaker, I would like to call on Dr. Akror Yakubov to talk about advances of endoscopic spine surgeries in Uzbekistan. Dr. Akror.
Assalomu alaikum barcha qatnashchilarga. Good morning. Welcome our conference. I want to thank for speakers and the participants for coming our stenoscopic conference. Today I will show what the advances in stenoscopic surgery in Uzbekistan, what we are doing now. Let me show our result. First, this founder of stenoscopic spine surgery in Uzbekistan, Professor Kangtak Lim from Korea. First, the Professor Shatursonov and Dr. Lim is above they told about history. First cases Dr. Lim in ProfMedService was in 2017. First I met Dr. Lim 2018 when he visited in ProfMedService. The time is when I saw stethoscopic surgery. I had too much interest to learn this surgery. My first cases was 2020. The cases was in summer. My first cases was is revision cases. I successfully done. This endoscopic surgeons by region in Uzbekistan. Initially, we are three. Dr. Delmurad, Dr. Shamansur, and me, who is learned from Dr. Lim, is our mentor. No, but nowadays we are teaching is our followers in Uzbekistan. By region, main is we are doing PSLD team in Tashkent. We are three surgeons. More doing is stethoscopic surgery doing, but we have is more than 5-6 followers. Now they are already started stethoscopic surgery. Main surgery we are doing in Tashkent, but is our other region, Andijan, Fergana, Samarkand, Khorazm. We established it not spine center, but is they are doing is stethoscopic surgery. About nowadays we are doing about 140-150 cases per month. Mainly two centers. In one is I work in in private hospital, ProfMedService. Dr. Shamansur, he works is Republic Orthopedic Center. We are doing about 120 cases per month, but our followers also 20-30 cases doing per month. Totally 150 cases per month. We are doing all kind of endoscopic surgery. What kind of surgery we are doing now? Full endoscopic interlaminar discectomy for lumbar spine, for endoscopic interlaminar ipsilateral and bilateral decompression for lumbar canal stenosis, multiple bilateral decompression from one skin incision, full endoscopic paraspinal foraminectomy for lumbar foraminal stenosis, full endoscopic parasternal fragmentectomy for lumbar foraminal and extraforaminal disc herniation, full endoscopic interlaminar bilateral decompression for thoracic canal stenosis, and also foraminectomy and foraminectomy for cervical part disease. Now we are planning in the fusion in ACDF in near future. This is full endoscopic interlaminar discectomy. I want to show is my result. Discectomy. This is 3-4 left side disc herniation is there is shown before and after surgery is result MRI. Yes, a good result is after surgery is post MRI. There is no compression. Is root is totally free. This is full endoscopic interlaminar ipsilateral and bilateral decompression for lumbar canal stenosis. This patient is 4-5 canal stenosis. I have done is bilateral decompression. You can see is during surgery I took a photo. Is both root is totally free. Multiple level decompression. Initially I I had done is on each level different separate skin incision, but is now I'm doing from one skin incision 3 level decompression. There is 4, 5, 3, 4, 2, 3, 3 level canal stenosis. First, this landing point is should be 3, 4. The second 4, 5. Third is 2, 3. Now you can see is during surgery taking this photo is bilateral decompression is done. This foraminal stenosis 4, 5 foraminal stenosis L forward is compressing. I have done this before and after surgery. MRI is shown. You can here is X-ray picture is totally my hook is inside the canal. Is I totally is done. This is video. You can see totally. Is free, is L forward, is pulsating. Full endoscopic interlaminar bilateral decompression for thoracic canal stenosis. We know is thoracic part is danger area. You cannot do any traction. If you give is more compression, if you give more traction, its spinal cord will damage. That's why you should be very careful during surgery. But is nowadays we are doing any neurological deficits, any damaging of spinal cord. We are doing is completely bilateral decompression. There is severe compression of spinal cord. I did this totally decompression, bilateral decompression. You can see video also. There is bilateral decompression is done without damaging any nerve structure. For cervical, for cervical we are doing is if foraminal stenosis or is foraminal disc herniation with posterior approach, foraminal decompression in foraminectomy. This is here is shown before and after surgery MRI and CT scan after surgery. If you see, you can see there is a very small window to access interlaminar space. It's very safe surgery. You can go is posterior approach also is for cervical lesion, cervical foraminal disease. I mean, it's very safe. I show you. This video is foraminectomy is done. Root is free totally. From pedicle to pedicle is done decompression. Second one is disc herniation, which is shown on the MRI. Before and after surgery MRI is you can easily remove fragment with posterior approach if lateral disc herniation. Thank you so much.
Thank you. Thank you very much, Dr. Akror, for that very nice presentation. We now know what's being done in Uzbekistan because of that presentation. There will be a slight change in the program. Our next speaker will be coming online from Pakistan. Let us all welcome Dr. Sohail Tariq. He will be talking about anatomical considerations in endoscopic spine surgery. So he will be online, and please Dr. Tariq, if you're available,
You,
you're welcome.
thank you, Mr. Chairman, and thank you, the organizer, for giving me the opportunity to speak on this. But I'm sorry that I missed to visit your beautiful country and missed so many friends sitting there in the front row, Professor Bang Bang, Professor Lim, Fiji Ito, and so many others. You know, they're all good friends. And but having said that, that's how it is. I couldn't come in time because visa problems. So I think without any delay, I'll start with anatomical considerations in endoscopic surgery. Shall I start? You see, endoscopic surgery has a lot of advantages. There's no muscle dissection, there is no muscle damage, there's no denervation, and the patient is up and about quickly without any problem, and they are back to work very quickly within few days, as compared to when you open surgery is done with a lot of damage to the muscle and the nerve tissue, and patient have a sort of delayed, and ultimately they lose their some muscle function over the period of time. If you see their MRI, there is a fatty infiltration in those muscles which have been protected for some time because of open surgery. If you look at the research activity producing endoscopic surgery, I think there's a lot of activity going on in all of countries. There are so many experimental and therapeutic techniques which are being developed, and I think the Far Eastern countries and Europe has contributed quite a lot in advancement of endoscopic or spine surgery. And there are a lot of either there's a full endoscopic decompression or there's endoscopic assisted, and I think the lumbar spine is a main sort of focus where a lot of endoscopic surgery is being done quite routinely in quite a number of countries, including Pakistan and other Far Eastern and Asian countries. And you have all kind of surgeries from disc degeneration to the fusion to the discectomy to the endoscopic decompression or the treatment of stenosis. But I think it is it's important to understand the basic concept. In the open surgery, you localize the spinal problem with the traditional sort of imaging, then you palpate various bony elements of the landmarks, and then you open it, dissect it. Thereby, a lot of damage is done to the muscle attachment, to the denervation of the muscle, and ultimately they are closed down. And after the surgery is being done, you close down and you start rehabilitation. That takes some time for a muscle to regain its normal function. But on the other hand, in endoscopic surgery, you localize the target area with routine imaging, with MRI or CT scan. Then you palpate the target area, not with the traditional palpation, but through the help of imaging and through the endoscopes and etc. Then you visualize the target area and you carry out your targeted treatment, and you have a minimal collateral damage, and the patient is up and about in the same day, and they're back to work as quick as possible. So I think you can achieve the goal of surgery within a very small period of time with a minimal collateral damage, and that is a big advantage in endoscopic surgery. But having said that, my feeling is that one must know the full surgery, open surgery, before you go for endoscopic surgery, because sometimes if you do not achieve the target or you do not achieve the desired results, sometimes you have to fall back. So I think routine training in the open surgery is mandatory for going to endoscopic or endoscopic assisted surgery in area of interest. There are posterior interlaminar approach. There is a femoral approach. These are the two approaches. The posterior interlaminar approaches go through the, violate the normal anatomy of the multifidus muscle. You introduce various dilators. You introduce various sort of tubes or various instruments which are dilated, and they dissect away the muscle. You do produce some damage to the innervation of the muscle, but having said that, it's still minimal. And you can only do it through the, one level or the two levels through the posterior approach and through the very small incision. But I think the beauty is that foraminal approach gives you, very minimal damage to any muscle, and in fact, it's without any muscle damage, and you can go to the target area to the disc, and you can do the disc removal or treatment of a stenosis as desired in a given patient. One should understand the approach, interlaminar approach is only posterior approach. You can use either through the endoscope, and you can use either one approach, or you can use both approach, or you can use contralateral endoscopic lumbar foraminotomy, and you can use either one or the both sides, and you can use decompression from one to the contralateral, and you can do decompression both sides. I think inframedial edge of the rostral index level is of the lamina is important. You put in a dilator, and you target that area, put a dilators, dissect away the muscles, and through the endoscope or the tubular retractors, and then you can do the desired laminotomy and remove the ligamentum flavum and reach the target area. And once you achieve the target, you come out, and muscle will fall back in its place. If you look at the ligamentum flavum, they are attached to the rostral end of the lamina. I think that is important to understand, and that is where you should target, and you should do the laminotomy with a fine burr, and that will give you good approach to target area through the interlaminar fluid. But I think transfemoral target area is very important because it does not violate any muscle, and you can approach the what is called as a Camden triangle, and you can approach. This is the kind of minimal blood damage, the vascular damage. There is no blood vessel there. There is an exiting nerve root. There is a traversing nerve root that you can identify, and you can protect them with a specialized sort of duckbill kind of tube, and you can protect it. And you can approach the disc, and you can enter the disc, and you can remove the disc from inside out technique, and it's very safe, and you can easily remove the disc or do the fusion at that level. These are the various endoscopic procedures which you can do. But I think the important thing is foraminal approach, which gives you an access to the disc, to the exiting nerve root, reversing root, epidural space, and you can approach the superior facet, and you can also approach the axilla, which contains dorsal root ganglion, and you can remove the foraminal osteophyte. And I think this is a very safe approach, and it gives you a good amount of access to all the important tissue which are part of pathological process, and you can remove the pathology in these patients, especially in the acute herniation or into the osteophyte formation in the disc degeneration level, and you can remove the osteophyte from the facet joint, or you can remove the osteophyte and other hypertrophic ligament from the posterior part of the disc where the nerve root is exiting through the neural foramen. It is important to see the foraminal anatomy, and you can see this blue needle there inserted in this space in the foramen, and you can see there is a good amount of space there. This is a cadaveric specimen, but it gives you a good idea where the nerve root is there with the exiting and the traversing nerve root is, and where the disc is, and you can have a good access to the area. And it also gives you the furcal nerve branch, and that is very important because in a degenerative lumbar spine, the furcal nerve is important to be ablated to remove any pain which is generated through the facet joint in a degenerative spine. This is a foraminal approach. It gives you both posterior access and also through the foramen, and you can see this foraminal approach. You have to remove the part of the foramen. You have to dissect some sort of muscles, but in a foraminal approach, there is just a straightforward approach. You have to target the area under image intensifier. You enter there, you put a K-wires there, and then you can dilate. Dilators are placed on the K-wires, and then you can introduce the working instruments, and that will give you good access to the foramen, that will good access to the disc prolapse and foramen. This is This is the anatomical aspect of the lumbar spine at the various levels, from the upper lumbar to the lower lumbar. And you can see this, the zone which is important, which forms a triangle, the Kempin's triangle, it varies because of the anatomical variation angle which forms between the exiting nerve root and the traversing nerve root. And these are not fixed. These are variable, and you can, this will give you a good idea, the amount of size of the instruments or the various anatomical factors at various lumbar and the upper lumbar level, and also at the thoracic level. But I think in all the lumbar spine, it gives you good access. You can put an instrument safely and without damaging the exiting nerve root, and you can approach the disc, and you can remove the offending disc or the osteophyte or other materials. This is how the anatomical sort of specimen is in a diagrammatic fashion. There's exiting nerve root, there's traversing root, and there's the base of the disc, and there's space. It's an ample space, and you can identify on image intensifier. You can identify the entry point, and you can be safe without damaging any nerve or irritating any nerve or damaging durosac. And you can approach this area and put your instruments and do the appropriate dissection. If you look at the anatomy comparison between posterior and the foraminal, I think the foraminal approach is much safer, and it gives you much more sort of safer process. But there's some problem is there in the L5 and S1, which I think I feel that posterior approach is much better and safer as compared to the transforaminal in the L5 S1 area. The anatomical variation is there quite often. There may be nerve roots, there may be multiple nerve roots or coming from the same exit, the foramen, and you must be very aware of that, and there may be a thin nerve root. And so I think these variations, they are there. You can identify in the MRI examination before that, but sometime may not be visible on MRI, but you can see that. These are the sort of typical degeneration. You can see the annular tear with the granulation tissue, which irritates the dorsal root ganglion. You can do the decompression, and you can do the sort of nerve ablation, the radiofrequency ablation of the granulation tissue, and you can remove the pain, and you remove the granulation tissue through the endoscopic approach, and you can, remove the symptom of dorsal root ganglion and the paresthesias. These are degenerative changes in the lumbar spine, right from the disc prolapse to the spinal stenosis. You can approach all these lesions, all these pathological process through the foraminal approach, and you can decompress the disc, you can remove the offending disc or the prolapse disc and through the disc level, or you can remove the osteophyte for the exit foramen using various bursts, and you can do the stenosis decompression quite effectively and quite easily through the transforaminal approach. If you look at the osteophyte, there stenosis mainly in the exit foramen is there. There are osteophyte formation from the fascia, and there's also osteophyte formation from the disc level, and they both encroach and produce foraminal stenosis with pain and paresthesias with impingement of the nerve root. And you can use the transforaminal approach. It will give you access to the osteophyte. You can burr them out, you can remove them with a various kind of burr, and you can, if needed to, you can institute the, you can put the fusion at the same level to the same approach without any problem, and you can put a cage as well, depending on whether it's required or not. But I think a transforaminal approach gives you good approach, not only acute degeneration, but also in a stenotic situation. This is a discectomy and the thermal modulation of the granulation tissue, which gives you good relief of pain, which is persistent because of granulation tissue in the annulus fibrosis, and that causes a lot of pain and sort of irritating pain, which is sometimes irritates the dorsal root ganglion, and that can be taken care by this thermal modulation through the endoscope. The other approaches which you can use is minimal access approaches through the spine. You can use posterior lumbar interbody fusion, anterior lumbar oblique, or the anterior to psoas approach. And in this, I think MRI examination at the lumbar level, which is our required, desired level of lumbar, you can see the blood vessels, the vena cava, aorta, and the psoas muscle, Mickey Mouse, where they are, and that will give you good access whether you can approach through the psoas, or you can anterior to the psoas, or and that will give you good access, a good idea of how to access the area. But the important thing is with a direct lateral or extreme lateral approach, there is this lumbar plexus which is there, and that is liable to get damaged in this. But I think you have to keep the anatomy in mind that most of the lumbar roots, they are in the lumbosacral root, they are in the posterior part. And it varies its position, whether it's a patient is prone or it's supine, and whether the legs are extended or flexed. But the important thing is they are lying posterior part of the vertebral body, and you can identify them, you can locate them, and you can monitor them with a sort of neuromonitoring, and you can see whether they are safe, and you can approach the whole lumbar spine through this lateral approach, and you can cause minimal damage in terms of thigh numbness or hip flexion weakness, which can be there in a certain number of patients. So I think it is important to neuromonitor, and important to maintain or keep in mind the location of the nerve roots in the lumbar spine, and whether proximity to the approach. You should again, you should go in the middle or anterior third, and you should use monitoring in those patients. The anterior to the psoas, you can use this approach either oblique, pre-psoas, anterior to the psoas, or through the psoas. You can use various approaches. These are easy approaches, but I think again anatomy has to be kept in mind, and you can use finger dissection, and you can use sort of various endoscopes, and again you can use various either decompression, or you can use fusion, or you can use deformity correction through the same approach. You can use more than 2 levels with this through small incision, but if you have to use multiple levels, you can use 2 small incision, and you can use blunt dissection. And I think the important thing is you should hit the retroperitoneal fat, and you should approach the tip of the transprocess. Then again, you slide your finger anterior to the psoas, and then that will lead to the area of anterior to the psoas, or through the psoas, depending on then what you want to do with that. And I think it will give you good access. For that, you have to have a good sort of knowledge of anatomy of the abdominal wall, and you have to have a good experience of basic genosurgical skill, and then you can use various sort of anterior approaches. Again, as I said, that you must know how to fall back and do the major surgery if something goes wrong, and you don't achieve your target, or you don't achieve your aim. This is the section of the this plexus, lumbar plexus. You can see the various nerves which are coming out, and they are all going through the psoas muscle, and these are the painted blue. And this is once you have to remove the vertebrae, and how they are. They are mostly lying in the posterior part of the vertebral body, and the anterior half of the vertebral body, they are not sort of posing any damage to the plexus. So I think, but still the nerve monitoring, neuromonitoring has to be carried out in all these patients, so to be safe and not to impale or damage the nerve. So I think endoscopic or minimal invasive surgery, they have a lot of advantages. You can have a precise targeting without any collateral damage. The anatomical and pathological identification is important, and that will give you very targeted approach and target therapeutic solutions. And all the portals have their own anatomical variations and limitation advantages. I think the transfemoral approach gives you much better access at almost all the levels of the lumbar spine and the lower thoracic, and it gives you good access to the not only the disc prolapse or to the disc degeneration or the stenosis, but also any degree of instability and the deformity correction. So I think important thing is that you should know the anatomy. You should see the anatomy of the particular patient with the MR examination or the CT examination, and that will give you a good idea of any variation which can occur in any given patient. But I think by and large, important imaging, important anatomical knowledge, and be prepared for any surprises. That's important. With that, I appreciate and I thank the organizers to give me opportunity to speak to the august audience in Tashkent, and I hope next time I'll be there physically and meet all my friends and contribute whatever I can to my brother in Tashkent and Uzbekistan. Thank you very much indeed.
Thank you very much, Dr. Professor Tariq from Pakistan. I agree that before we start and doing endoscopic surgery, anatomy is very super important, and learning open surgery is also important as well. Now, I would like to call on Dr. Radchenko for Dr. Radchenko or Professor Radchenko Volodymyr is from Ukraine. He will be talking about the importance of the paravertebral muscles for the surgical treatment of the lumbar spine.
One second. Kimda savol bo'ladigan bo'lsa, hozir hammasi ingliz tilida bo'lyapti dokladlar. Kimda savol bo'lsa, qanaqadir savol tug'iladigan bo'lsa, ki bemalol so'rashingiz mumkin bizdan.
Dear ladies and gentlemen, dear colleagues, I thank you. I'm sorry. Aye. Help me, please. Okay. This is just come here. It's for me. Just come. No. Full screen. Yes. Can open. Yes. One moment. I do it myself. Okay. This one. No. Second.
Once again, for the participants who are here, if you have any questions, you can approach the speakers anytime, especially during break times.
Yes. Thank you very much for Professor Shohedar Sutursunov for invitation into the endoscopic surgery. I'm from Sietenko Institute of Spine and Joint Pathology. We have very nice and good contact during many years. And in this presentation, I want to ask you attention to the importance of the paravertebral muscles of the surgical treatment of the lumbar spine. Etiologically, degenerative diseases in the spine considered multifactorial. It's aging, hereditary factors, hormones, peptides, cytokines, inadequate stress, and most important is the weakness and atrophy of paravertebral muscles. You can see some picture from Atlas Anatomy of Sinelnikov, produced in Kharkiv Medical University. Function of paravertebral muscle is active movement of the trunk, postural support for the body, protection of the spinal cord and nerve thing, and mood supply of regulation to various drainage from the structure of the spine. The spine contains the rich vascular network which is associated with its contributors intensive round-the-clock functions. The venous network consists of 2 internal and 2 external venous plexuses, widely anastomosing with one another. Yes, of course. The pressure of the venous system is low, and the walls of the veins, the such seen as more elastic than the arteries. Thus, the venous system functions as a capacities low pressure, and the wall of the veins do not have the ability to contract themselves. Contraction of the muscles has the main impact of the blood flow in the vein, and the next is the arterial contraction. The paravertebral muscles must the problem to the arterial supply of the muscles and the intravertebral channel. You can see evacuated the metabolic toxic products after the conflict in the spinal canal. Materials and methods: clinical examination, CT scan, histological examination, experimental modeling, and statistical data analysis. In addition, we have analyzed 93 CT scans, the lower lumbar spine of the patients under the age of 21 and 12 healthy volunteers. To do 663 axial CT scan images were studied. Some areas of muscle connective and adipose tissue were selected of axial lies 710 millimeters. As a result, we have got various parametric and present for you new system to estimate of the muscles. You can see the right side red color. It's the muscles. Blue color, the connective tissue, and the yellow adipose tissue. You can see development change during the age. 5 years, muscles very good. 10 years, connective tissue. 20 years, connective tissue and adipose, and the next. You can see 20 years, 40 years, adipose tissue more, and 60 years, you can see connective tissue, adipose tissue, and a few muscle tissue. And different pathology, for example, instability, hernia, the control group, spondylolisthesis, you can see connective tissue and adipose, and stenosis during progressive old, the adipose tissue and connective tissue. Yeah. And the progress of degenerative diseases of increased age of accompanied by decrease of muscle tissue and increased adipose and connective tissue. You can see during 4 years. The values of angle extension of the time of retention body before surgical treatment, and this angle extension time and retention body after surgical treatment, you can see 6 months, 1 year, and most 1 year, 6. And the result of surgical treatment of all the patient deteriorate. So. With age, the content of muscle tissue decrease, and the content of adipose and connective tissue increase. This is a linear dependence. Result of surgical treatment now also depends on the duration of the disease. The worst results have patients with longer course of disease. You can see again the control group with muscle tissue and spondylolisthesis, stenosis. And on this diagram, the result of surgical treatment depending on preoperative severity. Result of surgical treatment and worse of patients who had higher content of adipose tissue and lower content of muscle tissue before the surgery. You can see the algorithm of prediction results of surgical treatment of patients with degenerative diseases of lumbar spine depending on the preoperative stage of the paravertebral muscles and the differentials experts. Some clinical examples. Number 1, patients 48 years old. There is a good result after the operation. You can see the picture. And the next patients with satisfactory result, say. And patient 65 years old, spinal canal stenosis, unsatisfactory result. And conclusion. It's established that degenerative changes muscles correlate directly with degenerative change of other structures of the spine and progress according to the diagnosis of following order: instability, hernia, spondylolisthesis, stenosis. Clinical signs of the less satisfactory recovery after surgical treatment are patient age 48 years, longer duration of disease more than 6 years, and diagnosis of spinal stenosis or spondylolisthesis. As a result of the analysis of the algorithm for predicting the result of surgical treatment, it was discovered that the main indicator which determines the unsatisfactory result of surgical treatment is a total fat content of more than 14.5%. Moreover, a significant amount of fat tissue was found both of the total content of adipose tissue and for the content of adipose tissue in each of the muscles separately. Thank you very much for your attention. Yeah. I want to show you during 20 years, every year we organize a symposium of ISMIS in the Kharkiv city. And I hope this picture before the war, I hope in the nearest future I can invite you to Kharkiv for the next symposium. In this time, I'm the former president of ISMIS. ISMIS is the oldest society for minimal intervention in spinal surgery, organized by Professor Kambin, Professor Hijikata, and Professor Schreiber from Switzerland, Hijikata from Japan, Professor Kambin, USA. Before me, the president has been Sun Ho Lee from South Korea, and after me, Professor Fessler from Chicago. And this time, Professor Otel from Hamburg, Germany. I invite you to the conference, for example, in the different countries, for example, Indonesia, Japan, and other countries. Thank you very much for your attention. Yeah.
Thank you very much, Professor Radchenko. Truly, we should start maintaining our core muscles. Let's start exercising. Yes. So thank you very much for that lecture. And now I would like to call on Dr. Bobur. He will talk on the comparative analysis of the outcomes of interlaminar and transforaminal techniques in removing disc herniation.
Ассаламу алейкум, дорогие коллеги, дорогие учителя. Рад вас всех приветствовать на данной конференции. Отдельную благодарность хотел бы сказать профессору Турсунову Хайдаршу Алиевичу за предоставленную возможность выступить на сегодняшнем докладе. Тема сегодняшнего доклада будет посвящена сравнительному анализу исходов при трансфораминальной и интерламинарной хирургии. История трансфораминальной хирургии началась с открытием треугольника, важного треугольника Кабмина в 1988 году. Интерламинарная хирургия начиналась с открытой хирургии, потом мы перешли в микрохирургическую хирургию, возникла тубулярная хирургия, и на сегодняшний день самым современным методом лечения является эндоскопическая хирургия. Выбор метода доступа всегда зависит от локализации процесса, от возможности хирурга и от оснащенности клиники. Выбор всегда за хирургом и за клиническим случаем. Несмотря на то, что существует много исследований на тему преимущества эндоскопической хирургии над открытой. Это первое исследование, второе исследование, третье. Таких исследований очень много, которые показывают преимущество именно эндоскопической хирургии. Но всегда мы должны задаваться вопросом, учитывая, что есть две школы эндоскопической хирургии, это трансфораминальная и интерламинарная, так все-таки какой же метод лучше? Одни доктора обладают трансфораминальной хирургией в совершенстве, а другие доктора обладают интерламинарной хирургией в совершенстве. Так, где же золотая середина, есть ли она вообще? Когда мы задаем себе такой вопрос, мы обращаемся к исследованиям, в котором собраны все анализы и проанализированы различные виды показателей. Самым последним метаанализом, который проведено на данное исследование, является исследование, оно азиатское, в которое собрано 18 исследований, 2000 пациентов почти, 1000 интерламинарной и 1000 трансфораминальной хирургии. Сравнивали данных ученых по следующим показателям. 18 исследований. Сравнивали. Первое — время оперативного лечения. Время в группе трансфораминальной и интерламинарной хирургии не нашлось отличительных особенностей с одной лишь разницей. Время оперативного лечения на уровне L5S1 при выполнении трансфораминальной хирургии было немного выше, чем при интерламинарной хирургии. Срок госпитализации — постельный режим. В данном анализе тоже не было достоверных различий в результатах. Третье — уровень лучевой нагрузки. Уровень лучевой нагрузки был намного выше при выполнении трансфораминального доступа на уровне L5S1. Но по самому важному показателю для пациента, это шкала VASH до операции, после операции, шкала ODI, по шкалам МАКНАП, не было достоверной разницы при выполнении той или иной хирургии. Следующий метаанализ — это от 2020 года, в котором собраны 13 исследований, которые в эти исследования не были включены исследования, которые были от 2023 года. В данном метаанализе также проведены исследования на тему кровопотери. По кровопотере не было достоверных различий, по времени операции тоже не было достоверных различий. Различие всегда в одном — это в лучевой нагрузке. При выполнении оперативного лечения на уровне L5S1 лучевая нагрузка на доктора всегда выше. Исследователи, которые оценивали, так как были разные группы, разные уровни, исследователи решили проанализировать то или иной доступ на уровне L5S1. Есть такое исследование, в которое было собрано 621 пациент. Выводом данного исследования явилось одно, что время оперативного лечения при трансфораминальной хирургии на уровне L5S1 выше, и уровень лучевой нагрузки при выполнении трансфораминального доступа тоже выше. Так как здесь сидят не только доктора, которые имеют большой багаж знаний по разным доступам, но есть доктора, которые начинающие, я бы хотел немножко рассказать про свой опыт и про свое субъективное мнение относительно эффективности того или иного доступа, так как я выполнил и ту хирургию, и эту хирургию. Мой путь начался с 2019 года в Краснодарском крае. Я прошел курс по методике тезис по трансфораминальной хирургии. Один из моих наставников, Борис Анатольевич, сидит в этом зале. В 2021 году в московские больницы были закуплены 30 стоек самого современного оборудования, стойки Joymax, и у меня появилась возможность оперировать таких крупных пациентов через такой маленький разрез. Это мой первый опыт самого крупного пациента. Второй опыт выполнения трансфораминальной хирургии дало возможность делать такие минимальные операции через маленький разрез и получать такой хороший визуал. Сейчас быстрее. Без звука. На экране видим освобожденный корешок. Следующее. С какими сложностями я столкнулся, когда начал трансфораминальную хирургию? В первую очередь в системе Joymax, ну не только в системе Joymax, но при трансфораминальной хирургии в первую очередь важна разметка и важна разметка уровня операции, потому что самым основным является правильно разметиться и правильно сделать доступ. Мне кажется, для начинающего хирурга, который только прошел эту хирургию, сделать сначала передний снимок, потом определение уровня, выравнивание замыкательной пластинки, потом сделать один снимок на прямой проекции, потом боковой проекции, потом сделать еще несколько снимков. Оно повышает нагрузку как на оперирующего хирурга, так и на пациента. А вторая — это вот про лучевую нагрузку. Я делал в среднем 10-15 снимков до выполнения доступа к трансфораминальному доступу. Третье — это стоимость. Немаловажное значение в странах Средней Азии и в СНГ в целом имеет значение стоимость оборудования, которое нужно для этой хирургии. Современная система и современные расходники для этой хирургии значительно дороже, чем для интерламинарной хирургии. Третье — это время операции. В среднем, так как я до этого занимался интерламинарной хирургией, трансфораминальная хирургия для меня была новым, в среднем у меня длительность операции всегда составляла минимум 2 часа. Кривая обучения. Даже те доктора, которые активно практикуют трансфораминальную хирургию, они говорят о цифре 30. То есть 30 оперативных лечений на трансфораминальном доступом является хорошим кривым обучением. Ну, это для начинающего хирурга, мне кажется, много. Я выполнил 10 операций и получил 2 осложнения. Первое осложнение — это рецидив грыжи диска, а второе осложнение — парез в стопе после оперативного лечения из-за возможного установки тубулярного, в общем, тубуса. Мой опыт интерламинарной эндоскопической хирургии начался уже в Узбекистане. С января 2023 года я начал эту хирургию здесь. Данная хирургия позволила мне оперировать также крупных пациентов через небольшие разрезы. И есть ли какие-либо ограничения при интерламинарной хирургии? Перед вами снимки пациента с многоуровневым поражением на поясничном отделе, с огромной грыжей на уровне L2, L3 и со стенозом на уровне 4-5. Я сделал такую операцию. Посмотрите, здесь можно посмотреть, какая визуализация, свободно выходящий корешок. Декомпрессия на другом уровне, что потребовало 2 небольших разреза в поясничном отделе. С какими уже сложностями я столкнулся в Узбекистане? В той клинике, в которой я начинал эту хирургию, не было аппарата ЭОП, и мне пришлось для разметки использовать мобильный рентген, и это всегда прибавляло плюс 5, плюс 10 минут к оперативному лечению. Следующий слайд. Так как у нас есть время, я могу включить про мой опыт. Я делаю дискэктомию на данном уровне. Виден корешок. С помощью крючка захожу под корешок и пытаюсь убрать оттуда грыжу, которая вышла. Финальный вид освобожденного корешка. Сложности и осложнения. Я сделал с 14 января 51 операцию и получил 3 осложнения. Первые 2 осложнения, это повреждение твердой мозговой оболочки, у меня было при первых 10 операциях. В последующем данное осложнение у меня практически на сегодняшний день у меня такого осложнения нет. И получил одну рецидивную грыжу, которую пришлось удалять хирургическим путем, эндоскопическим. Теперь хотел бы рассказать немножко про удобство интерламинарной хирургии. Первое удобство — это разметка. Для того, чтобы определить правильный уровень оперативного лечения, мне достаточно 3 снимков, одной боковой, одной прямой, и уже после разреза, после установки инструментария финальной, понимания анатомии. Для меня, как нейрохирурга, который всегда практиковал открытую микрохирургическую дискэктомию, было проще ориентироваться в пространстве при интерламинарной эндоскопической хирургии. Стоимость инструментов, по крайней мере, в Узбекистане для нас намного оказалась дешевле, чем при стойке другой. И еще одним удобством, самым большим, оказалось то, что у меня здесь оказались наставники, которые вначале поддержали меня в начале хирургии, и все. И пятая особенность, и пятое удобство для начинающего хирурга является то, что в случае возникновения определенных нежданных ситуаций всегда можно перейти, расширить разрез и перейти в открытую хирургию. Выводы. Я бы хотел подытожить словами такими, что человек должен выбрать хирургию, ту или иную хирургию, исходя от того, что он умеет хорошо делать и что будет хорошим для пациента. И всегда нужно ориентироваться на клинические результаты. Вот какой бы подход для пациента именно в клиническом значении для него окажется выше и лучше в том или ином случае. И важно обладать и трансфораминальной хирургией, и интерламинарной хирургией. Все, спасибо за внимание.
Thank you very much, Dr. Babur. I agree that we shouldn't focus on one technique. We have to learn all the techniques, and it's always based on the patient's indication. The patient should be the paramount indicator for what technique you're going to use. So thank you very much for that lecture, Dr. Babur. Next, I will call on Dr. Poitkovsky from Ukraine. He will talk about transforaminal and interlaminar endoscopy. Dr. Poitkovsky.
Лазерная указка есть.
Так, это же не надо.
Ее надо на экран вывести. Hi everybody. It is not too easy speak the same presentation like a previous speaker, but I would like to say something new for you about our experience. So let's compare transforaminal endoscopy and interlaminar, and let's find it perils and pitfalls. So endoscopic procedures is growing in popularity for the removal of lumbar disc herniations. Recent advances in surgical techniques allow for percutaneous endoscopically assisted bony decompression as well. As you know, the pain could be inflammatory and mechanical. Inflammatory pain is caused by the release of chemicals in the nucleus that irritate nerve endings in the annulus fibrosus. And mechanical pain is due to the physical compressions of nerve roots as a result of herniation. And what kinds of treatment options? As you know, conservative treatment, anti-inflammatory, physiotherapy, etc., epidural steroid injections, and nowadays, surgery, endoscopic surgery. There are three main approaches for monoportal endoscopy. It's a lateral transforaminal approach, posterior lateral transforaminal approach, and interlaminar approach. As for me, I prefer posterior lateral approach because when you use a lateral approach, it is not so comfortable to revise a disc space. You know why it is possible? Because of safe zone. And there are two main techniques, inside out and outside in. I prefer outside in because you can have a direct visualization of nerve root. It is a 1075 endoscopic microdiscectomy since April 2016. It is a 908 transforaminal approaches and 167 interlaminar. In this picture you can see Jaap Hoogland and Mariusz Miguel from Poland. They help us to start these surgeries in Ukraine. So let's compare lumbar disc herniation treatment with transforaminal approach and interlaminar approach. Transforaminal approach and how I do it. I use a Maximo set for outside in technique. And very important, it is a preoperative planning, especially in an L5S1 level, because high iliac crest could be impossible to perform the L5S1 transforaminal approach. Entry point depends on level. For example, L3, L4, I use the distance from midline 8-10 centimeters, L4, L5 from 10 to 12, and L5S1 from 12 to 14 centimeters. Usually I use local anesthesia with a slight general sedation. The needle placement should be in a tip of superior articular process, SAP. And the tip of endoscope placement depends on type of disc herniation. Also, the key wire placement depends on type of disc hernia. If it is a central disc herniation, the tip of key wire should be directly in the midline. If a patient has a foraminal, for example, or paramedian disc herniation, it will be a medial pedicular line or mid pedicular line. Okay, how can I press the video on? Technical staff, could you help me? Okay. So after the sub punction, I insert the key wire, and then I perform the small skin incision under the local anesthesia. And after that, I insert the soft tissue dilator, and also perform the X-ray in AP and lateral view. After that, I inserted the largest soft tissue dilator, And the next step, it is a Tom Shady insertion. After that, I perform the bone drilling using Max Moore set bone drills. And the next step, insertion the walk-in tube and insert the endoscope. First of all, you can see only small pieces of disc material, and you should remove piece by piece very slowly, because the nerve structure could be also very close near the tube. During the surgery, I use also radiofrequency electrode produced Eloquence company for stop bleeding and remove the small pieces of soft tissue. Big piece of this material I remove together with the endoscope. This is a little bit bigger piece of this material. And the next one, clinical example. Some surgeons who perform the open surgery very often tell me that it is impossible to remove a big sequester from the spinal canal using the endoscopy, but it is not true. I would like to show you a really big sequester. This is a sequester with pieces of end plates. Here I remove together with a tube. Next one. And next one. This is the biggest sequester, 8 centimeters. And the patient has a Cauda syndrome. This is a MRI before and after surgery. And what about the far-migrated disc herniation? Is it possible? Yes, it is possible to do. I use these instruments from Max Moore, this hook. And using this hook, you can remove far-migrated disc herniation. This is the entrance. X-ray control during the removing migrated disc herniation. And MRI picture before and after the surgery. Caudal migration, cranial migration, cranial migration. That's all about transforaminal endoscopy. And what about interlaminar endoscopy? Everybody knows how you can do it, and I would like to show how I do it. And one of the main indications, as for me, it is a L5-S1 level disc herniations and high iliac crests and far cranial disc herniation migration. It is more easy than transforaminal approach. You should make a marking and just insert the tube. After that, you can see a ligamentum flavum, flavotomy, and then you can find the nerve structures and remove the disc herniations. As for me, the main disadvantages of posterior surgery is that fact that you damage the ligamentum flavum and you damage the epidural fat. When you perform transforaminal approach, you should not damage the ligamentum flavum and epidural fat removing. X-ray after, MRI after, and our results. During the transforaminal endoscopy, right herniations, we have a 9.5%, interlaminar only 7%. Nerve root damage is the same, 0.5 and 0.7. Dural sac tear near the 2%. Infections near the 0.5%. And X-ray loaded average in transforaminal approach 35 shots, and during the interlaminar approach 10 shots. So conclusion, the transforaminal approach is better during the removing of medial, paramedial, foraminal, and extraforaminal disc herniations, and interlaminar approach better for medial and paramedial disc herniations. Transforaminal approach better for partial facetectomy if it is needed, sometimes impossible on L5-S1 level with patient with high iliac crests. For caudal hernia migrations, it is very difficult for transforaminal approach and good for foraminal stenosis. And interlaminar approach better for direct, easy access, less X-ray, best for L5-S1 level, wide interlaminar space, and cranial disc herniation migration. Thank you for your attention.
Thank you very much, Professor Piankowski. Very, very clear indeed that transforaminal and interlaminar endoscopy has its role. Our next speaker is Professor Albert Sofyanov from Russia. He will be talking about transforaminal approach for lumbar disc herniation and surgical treatment.
Okay. Possible to start? Good morning for everybody. Thank you very much for giving possibility to share our experience about our spine endoscopic surgery. The main topic about our lecture is about the transforaminal endoscopic surgery, and little bit discuss about us. I am from Russia. I am from Tyumen, and I am from Federal Center of Neurosurgery. It's our Federal Center of Neurosurgery now, very well equipped center, covered all field of neurosurgery, so more than 5,000 cases per year. So also spine surgery department, more than near the 2,000 cases per year. Yeah. You have equipment of our center, and you have our hybrid ICT operation room, just for spine surgery, well equipped. You see CT inside of the operation room with exoscope, microscope, endoscopes, and all kinds of navigation system included. It's possible during the interpretive time to make. So the history you know very well, all is about the spine surgeries. And now we understand what minimally invasive surgery is the trend for the development of the spine surgery in the world. So why we also take attention for this kind of surgery in our Federal Center of Neurosurgery. And you well understand the compare of open surgery and transforaminal surgery, and now we start also transforaminal surgery maybe from 2011 maybe, like this. we have experience so about this endoscopic surgery. But before I started as endoscopic ventricular surgeons, and so I have a lot of surgery before because I started as pediatric neurosurgeon. But now I also have experience with spine surgery also. You know very well Cambin triangle. So we have GeoMX technology mainly, but we have all EasyGo, Storz, GeoMX technology, but now mainly technology is GeoMX technology, the standard steps we have during this surgery. So standard setup, endoscopic setup we have. This is our setup GeoMX for the surgery. Instruments. This is the position, the standard position we like, we prefer. Position, and we have a marking of the surgical entry point. It's also just the speaker explained as before. It's anesthesia is a very important question. It depends from the surgical experience and the patient what he wants. Sometimes patients don't like the local anesthesia, so but we have all possibility, local and regional is no problem. So it's step by step I show our technology is a standard, but we use reamer, mostly ream, just to put the instrument inside of the foramen. We dilated the size, and this is the endoscopic set of the operation start. This is the size of surgical wounds. It's really minimum. This is the result after. And now I want to show you some cases in our experience. But sometimes it also depends if we use needle or maybe Jimchudi, a needle also possible. It just depends from the experience and the what means the fast track spine surgery. This is our case, standard case, facet joint, coagulation. But if you have some, oh sorry. Sorry. Standard anatomy. If you see the watch window, a lot of working by the coagulation, and you see if you not enough space or narrow foramen. You see the bone, lot of bone, for example. We use a lot of drilling. Not shame to use drilling. Just open the narrow foramen and give us freedom and space. And now standard technology dissection by the hooks and a lot of instruments. Most important in this kind of surgery is your orientation, the good orientation. If you have good orientation, no problem. If you lost your orientation, so it will be a disaster. Remove the hernia. This is a good anatomy. After remove the disc. This final step. Final step of revision. Good pulsation. So good decompression. The size is not so small. It's possible, so no limit. If you have big ones, you're possible to remove by the sheet together. Another case, MRI. This is the level. This is a compressed root. Localization by C-arm, the level, skin landmarks. This is very important operation table. Just do our set, another kind of set, the drill from Joymax, and step by step. Dilation, insert the walking tube, oh, sorry. And now we start the endoscopic stage. This is the standard, first to work by the coagulation. Most important to remove the ligamentum flavum completely. This is a very important step. Also, drills work, also very important. Not ashamed and not afraid to use drill. Even you use before reamer. Again and again, if you need, you use more drill. Just to open the hidden zone. And after, by the forceps, you remove the herniation. Also, not so small. You see the how we prepare the field, operation field. So it's thanks for my friend Kim from South Korea to help us in our first steps training, our learning curve. This is good anatomy after removing. Result after surgery. This is conclusion, this is standard conclusion, and I want to say a little bit about our possibilities for young residents. We have not only operation rooms, we have also good cadaver labs, not only for spine. You see a lot of our workshops about the endoscopic surgery, but also it's possible for young residents just to have experience in the skull-based surgery, for example, wide matter dissection, just to study neuroanatomy, vascular, not only endoscopic, but also microscopic, exoscopic, and so on. Also, even simulation training is possible. This is some special device for this kind of training. This is our schedule for this year, just for educational courses. So we open for collaboration, and we open for young, especially for young residents. Thank you for your attention.
Thank you very much, Professor Albert Safyanov. That's a very nice presentation. We will be having a short coffee break after this. After the coffee break, we will go back to the session room for the mid-morning session. We will call you back after 15 minutes, so you can use the washroom and the restroom and have some coffee. Thank you.
Coffee break 15 minut davom etadi. 15 minutdan keyin zalga qaytamiz. Iltimos. Hello. 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 Yeah. Hammadan iltimos qilaman, qatnashchilarga joylaringizni egallab olishlaringizni. Hozir boshlaymiz ikkinchi sessiyani. Please have a seat, speakers. We are going to start second session. Welcome back, dear guests. We hope you enjoyed coffee break and are ready to continue our second session. I would like to invite here speakers, Dr. Vladislav Kelmakov from Russia. His topic, possibilities of endoscopic treatment, migrated disc herniation for lumbar spine in his country. Okay, Dr. Madaman will present this topic. I would like to invite here.
Assalomu alaykum, hurmatli yig'ilish qatnashchilari. Good morning, mentors. Good morning, colleagues. If you let me, I will speak in Russian for everyone can understand. If you any questions, I will answer in English. My topic is possibility of endoscopic treatment, high migrated disc herniation for lumbar spine. Если мы вот эндоскопическая методика в позвоночнике, это самая новая и быстро развивающая методика. Если мы посмотрим литературный анализ, там в подмете можно найти много статей именно в последнее время. Вот наш один коллега из Пакистана уже представил эту статью, который вот в библиографическом анализе, какой страна больше вкладывает в развитие именно в эндоскопическую технологию. Здесь вот на эта статья уже вышла в 2018 году, но не терял свою актуальность. Вот китайцы именно в это направление, большинство публикаций относятся к ним. Сейчас вот сами знаете, Китай это не только фабрика мира, но это сейчас постепенно становится фабрикой научных идей тоже. Если вот разберем анатомической стороны эту проблему, вот можно подходить именно на грыжу диску, надо различать вот следующие области. Вот в позвоночном канале это центральная зона, субартикулярная зона, фораминальная зона и экстрафораминальная зона. Исходя из этого мы набираем подходящий доступ, подходящий метод лечения. А по миграцию можно различить следующие зоны. Это первая зона, верхняя вот high upward migrated и нижняя четвертая зона это far down migrated зона. Это, на этот примере показано, что в клинических случаях именно вот первая зона, вторая зона, третья и четвертая зона по миграции. Вот мы, исходя из расположения грыжи, мы выбираем эндоскопическую методику. Вот много бывает такой дискуссия, что лучше, вот интерламинарный лучше или трансфораминальный лучше. Этого я бы, личное мое мнение, это не надо это сравнивать, это несравнимое. Вот, например, как это сравнивают, вот, кто лучше оперирует, травматолог лучше оперирует или нейрохирург лучше оперирует. Вот здесь это абстрактный вопрос. Здесь тоже такая. Мы, вот, эндоскопическая методика пока нестандартна ни одного в стране, пока не прошел стандартизацию. Сейчас вот многие вертебрологов знает, что сейчас золотой стандарт это микродискектомия, микроскопическая микродискектомия. А вот эндоскопия пока уже, мы сейчас уже идет вот стандартизация, именно какой надо выбрать, что лучше, что нет. Мы должны, вот, исходя из, как будет удобно пациенту, как безопасно и как именно, и как будет хирургу удобно. Вот по расположению грыжа, именно вот концепция джоймикса именно такая вот. Из расположения грыжа мы должны относиться, мы надо выбрать подходящие доступы. Вот интерламинарный доступ. Когда? Когда интерламинарное окно большое. В нижнем уровне грыжи. Это L4, L5, L5, S1. Когда лучше трансформинально? Когда интерламинарное окно маленькое. Верхний уровень грыжа. Заднебоковые грыжи. Когда? Когда это экстраформинально расположены или субартикулярно расположены. Транспедикулярная методика, это когда нужен транспедикулярная эндоскопия, когда это высокомигрирующая грыжа диска. По нашему опыту, наша больница уже оперирована более 1500 пациентов, из них мы статистически анализировали 1300 пациентов. Из них мы выполняли вот фарлатерал трансфораминальным доступом 72 пациентов, транспедикулярно 15, трансфораминально по методику TESIS мы оперировали более 700 пациентов и интерламинарно более, около 500 операций выполняли. Вот интерламинарный доступ. У нее возможность очень широкая, но у нее в основном ограничение, если мы выполняем без резекции костных структур, тогда у нас будет один ограничение, это интерламинарное окно. Ну, особенно вот в нижнем уровне интерламинарное окно это большое, но мы выполняли интерламинарную дискэктомию. Это трансформинальный доступ. В трансформинальном доступе можно сделать все, что можно сделать в интерламинарном доступе тоже. Ну, там в основном преимущество в том, что там без резекции костных структур. Из них тоже можно удалить высокомигрирующую и высокомигрирующую грыжи диск тоже. Вот по локализации это срединная, парамедианная, заднебоковая и мигрирующая грыжи диска. Вот здесь некоторые разделяют вот, по методику это inside-out, outside-in. Ну, это тоже вот по методику тесиса в основном там выполняется интраканальный доступ и можно убрать высокомигрирующие грыжи диска. Это фарлатерал доступ, с ним показание, что срединно расположены грыжи диска с миграцией. Это транспедикулярный доступ. Транспедикулярный доступ это особенный доступ, который вот недавно описан. У нее в основном показание является по локализации первой зоны и четвертой зоны. Это высокомигрирующая грыжа диска. Впервые это описано в 2016 году вот нашим учителям, вот Ральф Вагнером, впервые в 2016 году. Вот особенность этого доступа надо зайти через педикулы. Вот здесь по пошаговым показано, что сперва мы зайдем, с иглой до педикула, потом устанавливаем расширители, и потом с ремером делается небольшое отверстие, вот примерно 8 мм, в который зашел потом эндоскоп, и с этой потом устанавливается порт, и затем удаляется грыжа диска. Вот здесь тоже показано, и эндоскопическая картинка тоже. По нашим операциям уже мы около 1300 пациентов, снижение боли по шкале ВАШ и снижение по шкале ВАШ в спине и в ноге. Вот на этом слайде показано, что снижено достаточно хорошо. И по шкале Осверти тоже были хорошие результаты. И вот наше осложнение. Вот основное я хотел остановить на осложнении. Вот у нас было вот повреждение твердомозговой оболочки без неврологических дефицитов вот 14 случаев, это 1,1%, и повреждение ТМО с неврологическим дефицитом у нас случится только 3%, повреждение корешка 2 случаев, транзиторное усугубление неврологических дефицитов 5 случаев, транзиторная гипалгезия 15 случаев. И у нас была ревизионная операция, вот 13 случаев, из-за недоубранного фрагмента мы выполняли 13%, это 1%. И у нас ранняя рецидива составила вот примерно около 6%. В основном это ревизионная операция, и ранние рецидивы у нас часто случится во время обучения именно в последних, именно вот в начальных периодах. Именно повреждение ТМО, повреждение корешка тоже в основном случился в ранние периоды обучения, ранние периоды вот, ранней операции. Вот здесь показано, что у нас 6% ранней рецидивы. Вот на этом слайде мы показали, что вот впервые у нас 20 операций, у нас была ранняя рецидива 15%. 1,4% мы не смогли убрать. Ну, это вот, ну, затем вот когда мы оперировали 100 пациентов, ну, это примерно около 15%. Вот сейчас уже более мы 1500 уже операций выполняли, но около в районе 4%. Здесь вот надо помнить, что вот другие коллеги или другие авторы могут показать еще низкие показатели. Вот наша методика, вот наше направление такое, что мы удаляем грыжи диска без повреждения, без резекции костных структур. Там канал мы не расширяем. Вот большинство, некоторые эндоскопические операции выполняются с костной резекцией, интерламинэктомии и другие. Там будет достаточно большой канал, и она расширяется, и если повторно впячивается какой-то часть грыжи диска, ну там оно не вызывает никаких клиники. А у нас нет никаких резервных пространства, если возможные раннее впячивание, оно дает свою клинику. Спасибо за внимание.
Thank you so much, Dr. Madamin, sharing us your experience. Our next presentation, Dr. Verma from India. I think he's not here still. We can start the next presentation. Dr. Radchenko from Ukraine. From Ukraine. Dr. Pentovsky from Ukraine. His topic, minimal invasive endoscopic treatment of foraminal stenosis.
Dear colleagues, my next presentation is about foraminal stenosis and about minimal invasive endoscopic treatment of foraminal stenosis. So, the goal of our presentation is to analyze and describe appropriate surgical indications for endoscopically performed transforaminal decompressions with the outside-in technique, with foraminoplasty in patients with lateral stenosis, with and without herniated disc. Material and methods. A retrospective study of 357 consecutive patients undergoing percutaneous endoscopic transforaminal foraminoplasty and microdiscectomy at 377 levels was conducted with intent of identifying appropriate surgical indications in patients with radiculopathy. The mean follow-up was 12-24 months. So what are the factors of nerve root compression in the foramen? It could be a disc bulging, ligamentum flavum hypertrophy, facet joint hypertrophy, and compression of the nerve root between the bulging disc and lamina, complete disc resorption causing the kissing spine, and spondylophytis, sclerotic spondylophytis. We divided the static source and dynamic source of foraminal stenosis. The static source is osteophyte, superior foraminal ligament hypertrophy, disc compression, and facet joint compression. You can find in the radiologic investigation foraminal stenosis. You can see the foramen and L2, L4, L2, L3, L3, L4 is normal, and in L4, L5 it's completely narrow because of hypertrophy. In MRI diagnostic, you can also see the nerve root could be crowded in the foramen, and it could be a course of foraminal disc herniation. And dynamic source, it is instability. It could be a source of foraminal stenosis. So in this scheme, I would like to show the source of dynamic instability and source of dynamic stenosis. In our practice, we use a Lee classification. It is very important. There is a 3 zone of foraminal stenosis. The first zone is entry from dura to the pedicle. The second zone is the middle, medial pedicle wall to center pedicle, and third zone is the exit zone from center pedicle to lateral border of the facet joint. Okay, the next scheme, we would like to show us that there are 2 main factors of compression of nerve root, ventral and dorsal. And during the transforaminal approach, you can remove these 2 factors of compression. You must do it. The same set like transforaminal microdiscectomy, Max Morse set, bone drills, and the surgical techniques completely same. You can use normal approach, the posterior lateral, for facetectomy. So the first step, it is a Tom Sheedy needle insertion. You should put the Tom Sheedy into the saw-up, and it is the first step. After that, you should insert the Tom Sheedy needle to the middle pedicle line and change the sharp tip of Tom Sheedy into the blunt shape of the Tom Sheedy. And the next step, you can insert the Tom Sheedy directly inside into the spinal canal. After that, you perform the bone drill insertion of foraminotomy. In this video, I would like to show you how I drill the saw-up. It is 5 different bone drills from 4.5 millimeters to 8 millimeters. And during drilling, you should press your bone drill a little bit down and cut the upper part of the foramen, so you should cut the saw-up. But sometimes normal bone drills from Max Morse set, it is not enough. So we use another device. It is also bone drill. you can connect it to the automatically device and drill in the more and more bone tissue. Also, we can use from another company, for example, from Wolf, but it is really expensive. In Ukraine, it costs around 1,000 euro only for one surgery. So we prefer to use this device from Maxmore. It looks like this. And unfortunately, video does not work. And after the surgery, you should have this picture, complete foraminotomy in the second and third zone. And you can see that in the first zone, it's a little bit difficult to do transforaminally. So if we have a patient with a foraminal stenosis in the first zone, we use a posterior approach, monoportal or UBE. After the bone resection, you should remove the ventral factor of compression, for example, the disc bulging. So endoscopic microdiscectomy if it's necessary. It is a normal video, you saw this. And the small pieces of ligamentum flavum and the posterior longitudinal ligament you can remove using the radiofrequency electrode. And endoscopic inspection of the exiting and traversing nerve roots. So what should we do in cases of dynamic instability? We should stabilize. But during the stabilization, we should make a posterior fusion. How to do it percutaneously? We have our own set for facet joint cutting. It is a different diameters of cutters, depends on diameter of facet joint from 12 to 24 millimeters. And how I do it? The first step, it is a facet joint puncture, then key wire insertion, soft tissue dilator insertion, and working cannula insertion. After that, we insert the facet joint cutting, and we provide a decortication of facet joint and put it, the bone grafting inside. Clinical example. It is instability in fall 5 with foraminal stenosis and disc herniation. I perform the transforaminal foraminotomy, discectomy, and facet joint cutting with minimal invasive transpedicular fixation. It is a Medtronic sextant. And you can see that the patient under local anesthesia. Say hello, our patient. This is a wound after the surgery. So all the compression and stabilization was performed under the local anesthesia because of heart disease in this patient. So our results, according to the MACNAP criteria, excellent and the good results were obtained in 90% of patients with monoradiculopathy with lateral stenosis in a 2 and 3rd zone. The mean WAS score decreased from 7.5 plus minus 1.5 operatively to 2.8 at the final follow-up. Concomitant extruded disc herniation were recorded in 121 patients and 47 patients that had contained disc bulging. There were no approach-related complications. 10% of patients also with lateral stenosis in first zone needed interlaminar approach, or UBE, or monoportal. Thank you very much for your attention.
Thank you, Dr. Piankowski, your nice presentation. Our next speaker is from India, Dr. Siddharth Verma. His topic, advantages of PSLD, how to start snipping.
This side.
So thank you very much, and special thanks for giving me this opportunity to present this technique, which is now, I think, becoming most popular across the world due to hard work of the beginners. And I will focus on advantages and how to start sniping. So we often call it sniping because it is a very targeted technique, and it's quite contrarian to the earlier method which was used, and which was quite crude in the real sense. So the major advantages which probably will force anyone to start this technique as soon as possible is, number one, the lower complication rates post procedure. So I'm talking about not only the surgical complications, but the incidence of failed back surgery or post spinal surgery pain syndromes. In addition, there is less or almost negligible blood loss as compared to the open procedures, and of course the hospital stay is very, very short, maybe 1 or 2 days. A maximum patient can go home, and this brings down the cost to a great level, and especially important in today's scenario of cost effectiveness. But the major part which will probably interest most of you is that you can do multiple levels with a single incision, and I will just quote some papers. And I think this technique, which is now known popularly as the jumping technique, is extremely popular in all over the world now among the endoscopic enthusiasts. So for the use cases, if you see, I think you see this picture I have taken from one of the paper published by Dr. Lim and the team. So in cases where the lamina is big enough, that is around 10 millimeter or more, you can easily go on the same side as well while preserving the facet joint. We were talking about destroying the facet joint, but now I am talking here about preserving the facet joint. And I think you can see here, this is the post procedure CT, and the whole joint is preserved, and this is the technique which is done on the same side, approaching on the same side, and also the disease is also on the same side. On the other hand, if the vertebra is oblique, or if the lamina is shorter, as in if you go to the higher levels, or for example in thoracic vertebra, then you need to preserve the facet joint, you need to go parallel to it, and as a result you should enter contralaterally. So here also you can see how beautifully the facet joint has been preserved, and both the joints have been preserved, and it's quite I would say it is a God-given procedure, which we can preserve most of the anatomy and still go ahead. So I'm relatively new. Before October 2022, I was not knowing about this procedure, and this is how I started. And I think those of you who are looking to start this procedure should have this similar curve. First thing is you have to convince yourself. Some of you are already doing open procedures, some of you are doing and utilizing various approaches. Rather than becoming the slaves of the techniques, why not just see some techniques with the open mind and then apply as per the patient, so that this first step is extremely important. So try meeting some people who are doing this procedure and convince yourself that this is something which is good for your patient as well as for yourself. Then the second part is learn the technique. There is a steeper learning curve because it is something which is new. Although theoretically, those of you who have done any laminectomies, I'm sure most of you have, the approach is almost same, but the handling of the scope and all has to be learned. We say it's an art. So you need to learn this technique, and then of course you have to equip yourself. You are only as good as your instruments. So you should have a basic set of instruments which cannot be compromised upon. This is my humble experience, because otherwise you initially, when you are not aware of the structures completely, if you are also struggling with the instruments, it's going to be extremely difficult for you to start. Then of course perform some cases under supervision. This is just for patient safety, maybe 1 or 2 cases for those of you who are experienced, and then maybe the curve can start. And if you feel confident enough, I know people who have started, who have just gone, observed, and then started slowly. So start initial case selection, start with L5S1, then move upwards, and then I think it should be good. Now complication management is something which you should also learn, because if you create a dural tear in the anterior abdominal space, it is better to be repaired then and there rather than closing it and then coming out and then letting the patient get some symptoms and then praying to God, oh God, please save my patient, and then it's going to be very difficult. Or maybe then trying for an open thing. So sky is the limit, but you need to start somewhere. I'm going to just show the basics of this technique, which for the clarity of the images, again I have taken from one of the published papers. So you can see that this is just one AP view which is taken, and you want to land on the spinolaminar junction, and the dotted line is the one where you will put up your incision, and it is a 7 mm incision, and a 10 number blade is good enough. And you can see you can land either upwards or maybe slightly downwards, as in the second case. But whenever you start to do the laminotomy, you always have to start from this position 1. So you have to come down at the lower margin of the upper lamina, and then you have to start at this spinolaminar junction, and then you can go on from there. So for the technique part, this covers very beautifully the steps where you have to go from 1, 2, 3, 4, and if you see this B picture, these are all outlined. So you start from the spinolaminar junction, go on to the lamina, which is the lower margin of the superior lamina, and then you go on from the sides to the lower lamina, and your end points are always the points where you start seeing the abdominal space, and then you can just peel the ligament like a paper, and sometimes use the Kerrison's to remove it. I'll skip this. I think you'll see most of this. So these are the clear images which probably once you are expert you will see. But these are my pictures, so this is what you will actually see when you start. So it will all appear hazy, and it will be difficult other than if you don't have the orientation. So you see the textbook, and this is my real image. So there is a hell lot of a difference once you start. So if you don't have the orientation of your scope, which is caudal, which is cranial, which is medial, which is lateral, that's the most important. And if you change the scope view, everything changes, because you only have this is a monoportal technique. So if you change, you can land anywhere. Okay. So however, once I clear something, then I also start to see similar picture and try to make it like the textbook, and as our teacher has taught us. So initially when you start, you may take a little bit more lateral shoots or AP shoots just to be sure, but gradually your shoots will become less and less. And when in my first few cases which I did with one of our colleagues here, so I think we took around, and in the subsequent few cases which I did myself, I did not have to take maybe 4 or 5 shoots. So that was the beauty of the technique. So there will be a learning curve, but slowly as you go around, the things will be better. So fortunately, or rather unfortunately, I have not experienced any complications as of now, but there is a reported incidence of 1.9% dural tears, and the better way is to put it then and there for the inner layer as well as for the outer layer. So you can see this tachoseal is kind of a boon. In India, we don't have these availability, so we keep the Surgiseal handy, and just hope that we don't get this kind of complications. The complications get reduced if you use the hook and try to separate the adhesions before you kind of cut the flavum. So just pass your hook below, and that may reduce the incidences. Another common complication is epidural hematoma. The infections are quite rare, but can still happen. So guys, here is something, today I am speaking to this august audience, but we have very few published papers. If you go and do PubMed search, you get very few papers which are available. So I hope since many of us are doing so, we'll see more and more research coming up on this topic in the near future. So these are few references which are quite descriptive, and I hope you can go through. Most of them are from Dr. Lim and his team. So I leave you with this message. The people who are crazy enough to think that they can change the world are actually the ones they do. Spine surgery is experiencing a paradigm shift, and I think initially it may be difficult, but if you start, then soon one day it's going to be extremely nice. So with these words, thank you very much. I am from Mumbai, and I invite you all sometime please visit my city. We often conduct a lot of procedures for pain. So those of you who want to sharpen their pain techniques, please come here, and we hope to see you all soon sometime in Mumbai. Thank you very much.
Thank you, Dr. Verma, for a nice presentation. Our next speaker is from Russia, Dr. Abukov. His topic is overcoming barriers. Are there any restrictions for endoscopic surgery of degenerative spine disease?
Dear organizers, dear colleagues, I'm glad to be here. Thank you for invitation. My presentation will be, language of my presentation will be English, but I'd like to comment this report in Russian, because most part of this auditory speak well in Russian and know well Russian language. Ну, в моем понимании эндоскопическая хирургия представляет два таких глобальных направления. Это монопортальная и двухпортовая технология. Монопортальная технология, как все вы знаете, дает нам возможность 3 различных доступов. Это трансфораминальный, интерламинарный и экстрафораминальный. Двухпортовая технология также нам дает возможность интерламинального, трансфораминального доступа, а также выполнения спондилодеза. Основные принципы двухпортовой хирургии – это принцип триангуляции, когда рабочий канал и инструмент создают угол. При этом рабочее поле создается потоком воды и поддерживается потоком воды, как вот показано на этом видео. Хотел бы немножко рассказать о своем подходе к хирургии, эндоскопической хирургии. На уровне L5S1 я практически всегда использую интерламинарный доступ, при этом максимально сохраняя желтую связку. Как можете видеть на этом видео. Качество видео. При этом, когда выходим инструментом из канала, связка практически полностью закрывает промежуток. Связка практически полностью сохраняется. Что касается уровня LPS-1. Что касается уровня 4.5, 2.4, 2.3, 3.4, в моем понимании я использую интерламинарный доступ, когда грыжа с каудальной большой миграцией. Трансфероминальный доступ при отсутствии миграции, либо при миграции кверху. При этом в этом случае тоже я стараюсь максимально сохранять желтую связку. Вот как клинический пример. Огромная грыжа удалена, но при этом желтая связка максимально сохранена. Она отделена только в месте примыкания к суставу. То есть это как раз таки является основным важным моментом профилактики фиброза. При фораминальных грыжах, при большой форамине я спокойно использую трансфораминальный доступ. Однако при узкой форамине, при высоком гребне на уровне, если мы оперируем 4-5, либо при низком отверстии, мне больше нравится двухпортовый подход. Когда мы сначала выходим на корешок практически без резекции костных структур, и только потом из-под корешка достаем фрагменты. То есть первым делом находим корешок, потом удаляются фрагменты. Что касается рецидивов, наверное, часто сталкивались с рецидивом. Что делать в этом случае? Если изначально доступ был эндоскопический, интерламинарный, повторно я иду тем же самым доступом. Это рецидив, рецидивная грыжа через 2 месяца после первичной операции. То есть фрагмент удаляется тем же самым доступом через тот же самый подход. При первичной, если изначально была микрохирургия и грыжа без выраженной миграции к низу, в этом случае используется трансфораминальный доступ. То есть изначально был микрохирургический подход, при рецидиве используется трансфораминальный доступ. В данном случае у пациентки было 2 операции: грубый рубцовый процесс, грыжа на уровне диска крупного размера и с выраженной миграцией к низу. В этом случае был использован доступ бипортальный, без дополнительной резекции костной структуры. Эта резекция была выполнена еще при первой операции. При этом для выполнения доступа прекрасно подходят дилататоры Rivaspine, как будто они были для этого изобретены. При стенозе, при крупных грыжах центральных с синдромом конского хвоста тоже в последнее время мне нравится именно бипортальный доступ. Вот огромный фрагмент еле влезает, он громадных размеров. Вот верхняя картина — это до, внизу после операции. А слева внизу это едва заметный шов после операции. Пациент с нарушением тазовой функции полностью восстановился после операции. Второй такой же случай. Уровень 3-4, тоже с нарушением функции тазовых органов. Огромный фрагмент выковыривается из-под дурального мешка крючком, без тракции невральных структур. у пациента на фоне стеноза вылез огромный секвестр, который вызвал грубый неврологический дефицит. Вот, а вот это картинка после снятия швов. Что касается стеноза, в принципе, по мере накопления опыта двухпортовой, однопортовой технологии большой разницы в степени декомпрессии для меня нету. Но время операции при двухпортовой технологии получается гораздо меньше. Вот 3 уровня декомпрессии. Вот это сейчас видео с максимального уровня компрессии. 3 уровня сделаны из 3 маленьких разрезов. Вот это уровень корня дуги. Грубый рубцовый процесс. Это своя сторона. Диск. Противоположная сторона. Декомпрессия. Пациентка вертикализирована через 2 часа после операции, выписана на следующий день. Или вот когда несмежные сегменты, стеноз после стабилизации на уровне 2-3, над конструкцией и под конструкцией. Через 2 прокола выполнена декомпрессия. Это над конструкцией зона. Тоже прекрасно получается выполнить и под конструкцией. При этом, несмотря на то, что в этой зоне не было операции на 5.1, сформировался грубый рубцовый процесс гиперосификации. Тоже выполнена монопортальная система Ревоспайн без особых сложностей. Что касается фораминального стеноза, особенно на уровне L5S1, тоже после стабилизации использую двухпортовую систему, двухпортовую технологию. При этом резекция только вентральной части. Сначала находим корешок, и потом вокруг корешка создается пространство. Без резекции полной верхнего суставного отростка. Эти же операции можно делать пациенту. Пациент в сознании может с нами также беседовать, улыбаться. Также при ситуациях, в последнее время это не часто, когда требуется стабилизация, подтвержденная нестабильность на функциональную спондилограмму со стенозом, выполняем, используем двухпортовые системы спондилодез. То есть все манипуляции, как при очень похожи, как при микрохирургии. Удаляется диск, устанавливается кейдж. Перед этим выполняется декомпрессия. Если нужно, отслеживаются форамины своей стороны, с противоположной стороны. После, через вот такие 4 поперечных разреза, вот 2 разреза, которые используются для портов, потом через них устанавливаются винты. И с противоположной стороны дополняется. С хорошим клиническим результатом. Время операции примерно такое же. Что касается повреждения мышц. Вот выходим инструментом при двухпортовой. Видно, что мышцы смыкаются. Та же самая манипуляция при монопортальной. Также мышцы смыкаются. То есть степени повреждения мышц глобальной разницы сложно будет увидеть. При этом я никогда не использую, не отсепаровывая мышцы, 2 прокола, устанавливаются дилататоры и сразу устанавливается эндоскоп, без всяких дополнительных интеракций. В грудном отделе используем только монопортальную технологию. Вот секвестр на уровне TH10, TH11, МРТ-контроль. То есть подход такой же. Ни разу не пробовал двухпортовую, хотя был в Сеуле, видел, что даже 4 уровня делают двухпортовой техникой. Что касается шейного уровня, тоже только монопортальная и декомпрессия билатерального over the top, и удаление грыж, и даже осифицированных грыж с использованием ручной фрезы. Ревоспайн, она прекрасно для этих целей подходит. Можно ей же смещать корешок и ей же удалять, ей же смещать корешок, ей же резицировать осифицированную грыжу, либо остеофиты. Спасибо за
Thank you for a nice presentation, for your nice experience. Next speaker is Dr. Sechennikov from Russia. His topic is here. His topic is current possibility of endoscopic spine surgery.
Приветствую вас, коллеги. Я хотел сказать слова благодарности организаторам, которые организовали данное мероприятие. Столько прекрасных, замечательных глаз, эндоскопических хирургов, малоинвазивных. Это очень радует. Вот. Мой доклад посвящен возможностям эндоскопической хирургии. Я сделал более 3000 операций при помощи эндоскопии, поэтому поделюсь своим маленьким скромным опытом. У меня есть нюансы по компьютеру. Не выводится пока. Вот, все, отлично. Приведу несколько кейсов. Они, на мой взгляд, интересны. Я думаю, что и понравится и вам. Да, для любого хирурга рецидив грыжи диска и идти по рубцам, это есть определенные риски, связанные с чем? С повреждением невральных структур. К нам обратился пациент, ранее было выполнено оперативное вмешательство, в 2017 году была выполнена микродискоэктомия, к нам он обратился в 2019 году с выраженно-болевым синдромом и с неврологическим дефицитом нижней конечности. Правая МРТ, это 2019 год. Мы видим сверху, это рубец после микродискоэктомии, и внизу мы видим 5-7 мм. Да, послеоперационный рубец после эндоскопической хирургии трансфораминальным доступом. Ну, напомню, мы идем еще по девственным структурам, мы не встречаемся по рубцово-спаечным процессам, связанным с ранее проведенной операцией, поэтому, в принципе, сложностей у нас никаких не возникает. Так выглядит МРТ после операции. До, после операции. Грыжа диска L4, L5. Мы вот тоже с коллегой здесь немножко пообщались, да, вот центральная грыжа диска, вот, достаточно больших размеров, с компрессией, как пойти интраламинарно или трансфораминально. Я могу сказать, что я оперирую и интраламинарно, и трансфораминально, и транспедикулярно, поэтому сложностей нет. Ну, в данном случае был выбран трансфораминальный доступ. Вот, справа у нас окошко, то, что мы видим, и то, что я вижу на мониторе своей эндоскопической стойки. После удаления грыжи убираем остатки связочного аппарата, связок фораминальных, остатки грыжи диска. И конечная картинка должна выглядеть следующим образом. Напоминаю, операция выполняется в водном растворе, поэтому при изменении давления мы видим флотацию корешка и понимаем, что операция на этом закончена. Никакой компрессии мы не видим. Так выглядит пациент до операции, а справа это через пару часов. Данная госпитализация 16-18 часов. Ходить, сидеть ограничений нет, поскольку мы не затронули задние опорные структуры, поэтому ограничений таких нет. Интересный кейс. Обратите внимание, пациент, и интересность этого кейса заключается в том, что у нас пациент с тяжелой сопутствующей патологией в виде болезни Паркинсона. В Германии было выполнено 2 операции с периодичностью 2 месяца. Сначала была удалена грыжа диска на уровне L5-S1, потом каскадные моменты, у нас грыжа диска на L4-5, и к нам он уже обратился с секвестированной грыжей диска на уровне 3-4 поясничных позвонков. Мы видим, что качество жизни данного пациента оно у нас резко снижено. Так выглядит МРТ, мы видим секвестр. Секвестр у нас находится с правой стороны. Мы видим ранее установленную металлоконструкцию. Также мы видим ятрогенный стеноз винтом. Так это выглядит на КТ. А это то, что это его история, да, это его паспорт, что с ним было выполнено ранее. То есть спереди налив, 4-5 X-слив плюс 4 винта. Это рубцы от ранее проведенных оперативных вмешательств. Мы выбрали трансфероминальный доступ. И вот как мы показаны на левом слайде, да, при помощи специального микрохирургического сильно изогнутого инструмента мы удалили грыжу диска. Извините. Ну, вот так вот выглядит секвестр. Здесь мы визуализируем, да, свободное ложе, где было у нас ранее грыжа диска. Также при изменении давления мы видим флотацию корешка, что говорит об отсутствии компрессии. Кстати, есть работы, которые доказывают, что отсутствие прямого контакта с кислородом это также препятствует рубцово-спаечному процессу. То есть, если операция выполняется в водной среде, риски рубцово-спаечного процесса они гораздо ниже, и если даже есть, они менее выражены. А вот так вот выглядит наш пациент буквально через 2 дня. В среднем, я напоминаю, у нас госпитализация 16-18 часов, но поскольку у пациента болезнь Паркинсона, понадобилась консультация невролога, который скорректировал препараты по основному заболеванию. Сверху мы видим, видите, рубец после дренажа, да, где-то на час дня. А внизу у нас послеоперационный прокол после выполненной эндоскопической операции. Что интересного на этом слайде? Мы видим, да, есть грыжа диска, L5S1, это каждый день мы это видим. Что интересно, что вы скажете? Что необычного есть на данном МРТ? Коллеги, кто подключится, кто скажет, что необычного есть на этом МРТ? Хорошо, я сокращу время, оно ограничено. У нас есть плод 18 недель. Обратите внимание, данная девушка, она беременна. Да? Видите? 18 недель. Также мы выбрали трансфероминальный доступ. Немножко по ходу операции, как раз затрону, расскажу про возможные рецидивы грыж дисков и почему с длиной кривой обучаемости, чем больше сделали операций, тем меньше у нас рецидив. Так, что-то им у нас не идет. Не получится покрасоваться. В общем, хотел показать, да, в 2 словах. На данном видео показано, что данную грыжу я удалил за 3,5 минуты. Но операция длится 40 минут. С чем это обусловлено? Грыжу удалили, увидели где-то вдали какую-то флотацию, но тем не менее, неужели заработало? Но тем не менее, также были выявлены костная компрессия, поэтому была выполнена резекция также и костных структур, и данная операция была 40 минут. Сначала в своей кривой обучаемости я бы ограничился одним удалением грыжи диска, увидел где-то какую-то вдали флотацию, на этом бы ограничился. Ну, в данном случае позволить себе это было невозможно, и понимание ситуации, и саму девочку жалко, поэтому делали полную декомпрессию, чтобы 2-й раз туда не возвращаться. Да, да, конечно, все нормально. Вот я сейчас жду, контрольного МРТ нет, потому что в июне родить должна. Так, у меня опять зависло. Следующий слайд хотелось бы включить. О, сразу с козырей пошел. Ну, здесь ранее говорились о грыже грудного отдела позвоночника. То есть, да, напомню, я травматолог, и данные операции я раньше выполнял при даже не эндоскопически, а используя открытую хирургию с резекцией ребра. Видите, у нас есть грыжа диска, секвестрирована, есть опоясывающая боль, 9 баллов по шкале ВАШ. Также установлен порт. И вот видите, справа у нас есть как раз микрохирургический инструмент, при помощи которого мы удаляем данную грыжу диска. Мы сейчас видим на видео, у нас грыжа перед нами, и вот при помощи коагуляции, кусачек мы ее удаляем. И вот слайд справа, это как раз уже освобожденный корешок, который ничего не компримирует, никакой компрессии нет. Ну, также госпитализация 16-18 часов и быстрая активизация после операции. Кстати, я вот не использую местную анестезию, я использую общий наркоз, севаран. Ну, как бы по этому поводу не сильно страдаю, потому что у меня пациент просыпается сразу на столе. Контрольный МРТ, грыжи нет. Транспедикулярный доступ, классная штука. Ну, вообще, мне кажется, это самый простой доступ в эндоскопической хирургии, потому что, в принципе, мы идем и известные нам точки, да, то есть это то же самое, что установка винта по рокамилу, только мы изменяем угол. Также мы спокойно заходим и удаляем данную грыжу диска. При этом ножка она сохранена через 3-4 месяца, есть при контрольном КТ, к сожалению, у меня его здесь нет. Там следов, то, что там была резекция какой-то спонгиоза, там этого нет. И ножка абсолютно опороспособна, и пациент активизируется сразу. Часто использую интраламинарный доступ при стенозах позвоночного канала. Ну, классная вещь. То есть интраламинарно зашли, резицировали желтую связку, сходили контралатерально. Зависает МРТ. Ой, зависает, простите, видео. Ну, здесь у нас свободная флотация. Ну и послеоперационный рубец, после данной операции. Интересная, классная вещь. То есть мы часто видим и сами делаем вертебропластики, но бывает такое, что костный цемент, он распространяется в позвоночный канал. Ну, данный перелом, он патологический на фоне остеопороза. И представим ситуацию, да, если бы не было бы эндоскопии, что бы нам пришлось сделать. Ну, это нужна была ляминоктомия, да, поскольку переходный позвонок, то есть это большая инструментация. Пожилой человек с кучей сопутствующей патологии. Выбрали эндоскопический метод. Подождем. Ну, я могу сказать, там прекрасная визуализация, то есть мы видим костный цемент, мы четко видим то, что компримирует невральные структуры, да, и при помощи алмазных фрез мы спокойно этот цемент имеем возможность удалить из этого позвоночного канала, тем самым освободить. Ну что ж такое. Это конечная картинка, уже остатки хлопья белые, это у нас костный цемент. Ну, почему-то не запускается видео у меня. Кому будет интересно, на моем компьютере это работает, поэтому можете подойти, я покажу эти видео, нет никаких проблем. Также использую интраламинарный доступ при параартикулярных кистах. Ну, почему нет? Зашли, сделали прокол, да, удалили эту кисту, освободили невральные структуры. Видео не грузится. Здесь у нас свободная манжета. И вот мы видим контрольное МРТ. Хорошо, хоть контрольное МРТ включил, а не только видео. Мы видим, что этой кисты нет, и у нас невральные структуры освобождены. Интересный кейс, я думаю, мало где вы увидите, да. Здесь у нас осколочное ранение на уровне С1, С2. У нас, да, осколок прошел через позвоночный канал, остановился, тем самым он не повредил, к счастью, твердую мозговую оболочку, и пациент у нас с тетраплегией. Но он был взят сразу, в первый час, поэтому получили хороший результат. На следующий день у него уже он перешел в тетрапорез, и в принципе в течение месяца он восстановился. Ну вот сам тот момент, да, когда мы прошли, визуализировали. Плюс какой? Мы можем убрать все окалины, пороховые изменения, да, какие-то народные тела. В данном случае я здесь шел по раневому каналу. У нас есть возможность его хорошо отмыть, операция выполняется при постоянной ирригации водного раствора, поэтому данная рана, она зажила первичным натяжением. Там, после операции буквально там, повязка с левыми коленями, через 2 дня наводящий шов, и никаких ограничений, никаких воспалительных моментов не было. Молодой парень, 16 лет, пошел за хлебом, попал также под артобстрел, и мы видим, что осколок у нас находится на уровне первого грудного позвонка. да, есть возможность пойти и сделать открытую хирургию. В принципе, до эндоскопии я бы так бы и поступил. Но в данном случае я выбрал эндоскопический метод. Не грузится видео. Ну, на данном видео визуализация данного осколка, да, и при помощи коагуляции он был выделен, и при помощи микрохирургического инструмента он был удален из позвоночного канала. Все зависает. Друзья, и хотел бы я подытожить тем, что нет никаких школ, которые подразумевают трансфораминальную хирургию или интерламинарную хирургию. Есть показания, есть наши возможности, есть наша уверенность в том, что мы можем это сделать. Напомню, что с приходом эндоскопической хирургии, свою открытую хирургию, хотя изначально я оперировал так, Юмашевская школа, я сократил порядка на 80%. Я оставил это на травму, я оставил это на спондилолистезу. Поэтому все возможно, все в ваших руках. Есть к чему стремиться. Я уверен, что вы это много и делаете. Так что будьте здоровы. Спасибо.
Thank you, Dr. Boris, for nice presentation.
Да, кому будет интересно после конференции или в перерывах, я смогу показать видео. Я думаю, что у меня загрузится. Спасибо.
Next presentation is mine. Topic is PSLD technique and my learning curve.
У вас здесь было, да? Это вторая. Секунду. Смотрите. Я могу это сюда поставить назад. А там есть же. Не работает тоже.
PSLD technique and my learning curve. PSLD technique is very nice. Who wants to learn is like a game. Present PSLD technique. This is on the right side is scope and left side is joystick. This is like a joystick. You can do. You can give any direction. You can turn everything what you want. It's like a game. When you many participants played game. When you played game is you enjoy it. You like it game and you enjoy it. PSLD also like this. If you when you start PSLD surgery is you are doing not operation. You are playing like a game. What is basic techniques of PSLD? On the left side top, if you do like this approach far from the spinosus process, you will more damage facet, because when you going inside, when you're doing this approach, you have to remove half of part of facet joint. That's why is best way is just parallel of spinosus process. Your skin incision just beside should be beside the spinosus process. Just your cannula should stay parallel of the spinosus process.
And the landing point should be spinolaminar junction. When you put your scope spinolaminar junction, you first remove middle part of canal, and you have preserve, you have to save facet joint. In the future, if you don't save facet joint, you know in the future will be instability. That's why first important thing is your approach. If you do correctly approach, you will save facet joint. If you don't do correctly approach, you will more damage facet. When you put your scope, first you have to remove the spinolaminar junction. Is a short picture down. You have to remove spinolaminar junction, and you open middle part of the dura. Then from medial, you can go from medial to lateral. You don't need first bone working. Second is removing is the ligamentum flavum. Just make a space for your access, your instrument, your garrison, and should remove ligamentum flavum. From medial to lateral, you have to go by step 1 millimeter bone working and ligamentum flavum remove 1 millimeter bone working like that. You have to go from medial to lateral. If you do like that, you can save both facet. This is first L5S1 disc herniation. There is big canal. If like this situation, like this cases, there is no ligamentum flavum hypertrophy, just lateral left side disc herniation. That's why you don't need remove too much bone working. You don't need remove too much ligamentum flavum. Just 4-5 millimeter window, removing this much disc herniation enough. If you do more bone working, if you do opening more ligamentum flavum, after surgery will be adhesion. That's why you don't need to open too much. This why video is not playing? Yeah, video is not playing. Okay, second one is L1, L2. If you have like this is paramedian disc herniation, but with canal stenosis is high level, L1, L2, there is more nerve roots and narrow canal. If you have like these cases, you first have to do full decompression of full decompression. If you don't do full decompression, bilateral decompression, during to remove disc herniation, you will damage nerve roots. That's why L1, L2, L2, L3, or 12 L1. If there is no spinal cord, first you have to totally decompression, bilateral decompression. Then you should remove disc herniation. Third picture is 4-5. There is also left side small disc herniation, and if there is one thing is spinosis process tilted on the left side. If you do a left side approach, you will more damage facet, because when you are reaching is to the disc herniation, you have to do more bone working. That's why this contralateral approach is the best. You will save facet, and you don't need to remove too much bone. You can easily reach contralateral side and remove disc herniation. This is if you have one level bilateral foraminal stenosis L5S1, both right and left side there is foraminal stenosis. If you like these cases, what you do? You don't need First do is right side, second everything is changed opposite side. You don't need do like that. No, from one side you can do contralateral side. First ipsilateral side you have to do is spinal approach and do it. One root is L5 root decompression, and second step is interlaminar approach. You can go and contralateral side, and you can reach both nerve roots. There are you have to decompression is one in L5 nerve root. One time you can do is both foraminal stenosis. You can do both foraminal stenosis decompression. This is how we can do is foraminal stenosis. There is landing point is eastmost. You should land with your scope on the eastmost, and with this mode we can do drill. We use because without drill we cannot do decompression. Is independence patients before surgery on the MRI we should check which size from medial to lateral, which skin incision we have to marking before surgery. We have to plan, and for example 5 is 1 because of sacroiliac. You cannot skin incision. You cannot do more than 5 centimeters because sacroiliac is disturb your scope. For 5, 3, 4 you can measure from medial at least 5, 6 or even 7 centimeters from medial. In skin incision you have to mark, and you can do. This is easy to do foraminal stenosis. The last picture there is shown. CRM picture is I checked when I finished surgery. There is inside my hook is inside. It means this root is totally free. This is thoracic. Thoracic is very a danger part of spinal cord. We have to be careful more. When you use the thoracic part, you need high speed drill, and you cannot use big size of Kirsten punch. If you use big size of Kirsten punch, you will damage spinal cord. That's why 1 mm or maximum 2 mm Kirsten punch is enough to do decompression. Cervical also like this. Cervical first before surgery is on the X-ray, the middle C6, C7 foraminal stenosis. First we have to find V point is interlaminar point. V point. If you find the V point is this is axis point into the interlaminar space. You can do so from when you do decompression foraminal stenosis for cervical part, from pedicle to pedicle we have to open if you want totally decompression of the nerve root. This is my learning curve. How I learned PSLD surgery. When I saw first time when Dr. Lim visited in ProfMedService, I had too much interest to learn this to do this PSLD surgery. I had planned before pandemic, before started pandemic, to go to the India and to go to the Seoul, Korea, and to learn this endoscopic surgery. But unfortunately, this pandemic started. But my every plan is cancelled. But this every time is you have chance. One door is if one door is closed, second will open. That's why is during pandemic I tried to find a way to learn PSLD surgery. The time, after some times, I had this good idea to do PSLD surgery. I got this ship, and because in hospital I had this every equipment, instrument, everything. I got this vertebrae of lamb, and regularly I was doing everyday surgery because under microscope I could do is microdiscectomy. Only I need to learn maneuver of PSLD, how to hold scope, how to use instruments, which direction. Everything is I learned this on the ship because in Uzbekistan cadaveric workshop is not available. I recommend to young surgeons mainly who is sitting here. You can do also same thing which I did, because if in our countries cadaveric workshop is not available, best thing is to get equipment, PSLD equipment, and you can do the same thing which I did. By the time is 2020 and now 2023 is when I started 3 years before is per cases I did 3 hours, 2.5 hours, one level. Now is one level 30 minutes I do. Now is I have is more patient is from that time till now I have done more 1,000 cases. Thank you.
Thank you. Thank you. Thank you, Dr. Akhlal, for your sharing your experience with us. It's everybody has its own learning curve, and your learning curve is very interesting. And using the ship for the PSLD is it's a really good idea. It's an idea from the Dr. Lim. So our next presenter is Dr. Kandimov Dilmurod. The title of the presentation: Our Experience of the Lumbar Canal Stenosis Using the PSLD Method. Please, Dr. Kandimov.
Доклада пропустили сейчас только что. Вот этот и вот этот. Начал читать Ахрор, и сейчас только Дима поставишь.
Assalomu alaykum, hurmatli ustozlar, hurmatli hamkasblar. Good day, dear mentors, dear colleagues. Let me introduce my presentation. My topic is our experience of lumbar canal stenosis endoscopic treatment using PSLD method. As we know that for the last decades, increasing aging population leads to the increasing cases of lumbar spinal stenosis patients. So it demands from our as spine surgeons to have in our armamentarium the good and safe method to treat lumbar canal stenosis. We choose it as a surgical method of treatment, PSLD, using the PSLD set of instruments with PSLD scope, 120 millimeters length and diameter 8.5 outer diameter, and working channel 5.7 millimeters. Other instruments almost the same as open surgery. How I select my patients? Most of the stenosis patients with stenotic MRI images associated with NIC, neurogenic claudication, or neuroischemic symptoms, sometimes including the radicular type symptoms. We use the MRI grading system classification by Shizas, mostly with MRI stenosis grades C and D. First step in the surgical room was level marking under lateral C-arm projection. Dilator is placed by palpation near besides the spinous process over the index level. Then the skin incision made beside the spinous process, and dilator inserted along the spinous process through the factor plane between spinous process and multifidus muscle, so that we can save multifidus muscle. Schematic diagram shows how we did laminotomy. There's caudal edge of the cranial lamina, lower edge of the cranial lamina, spinal lamina injection, then removal of the middle part of the ligamentum flavum, then removal the lateral part, then going to the contralateral side. We performed in the time period from 2021 till now. We performed almost 300 almost 300 patients underwent lumbar spinal stenosis surgery. From them, 138 male patients and female patients 154. I didn't have much time to make the differentiation to the leveling. I mean, how many patients was one level, how many patients was two level. That's why I didn't insert this information to this slide. So let me go through the cases, some cases. It is my one of my initial cases. This patient, 61 years, which was complaining to the buttock and leg pain with neurogenic claudication, distance 100 meters. He was unable to stand in upright position more than 3 minutes, with history of increasing aggravated symptoms for 6 months. This patient on MRI had 2-level stenosis, L3, L4, and L4, L5. But it was my beginning stage in my experience. I did decompression in 2 stages. Initially 1 level I did, but and after 2-3 weeks I did 2nd level. Here we can see that after this we can see that after the compression the spinal canal is noticeably widened, and the rootlets can be seen separately at L3, L4, and here at L4, L5 levels. On this X-ray, we can see the borders of decompression, uppermost level of ligamentum flavum attachment, and the lower border is the middle of lower pedicle. Next patient, 63 years, with the back, buttock, and right leg pain. WAS score was 8. NIC distance 200 meters. He was unable to keep standing position more than 5 minutes, and durations of symptoms was 10 months. On preoperative images, we can see grade C stenosis according to scissors. And after percutaneous endoscopic decompression, we can see the widened spinal canal. And after widened, the symptoms decreased. Back pain, he has a little bit back pain, but back and right leg pain absolutely really released. And walking distance after 1 month, he was more than 1 kilometer. So next patient, 67-year female patient. She had back, right leg pain. WASC score was 7. NIC distance was 50 meters, and she was unable to stand more than 2 minutes. Initial symptoms started 2 years ago, but gradually it increased, and 4 months ago it was severe, so that she visited our hospital. Here we can see the severe stenosis at L45. Preoperative image, and after the stenoscopic decompression, we can see a good widened spinal canal. Next day after surgery, back and right leg pain absolutely disappeared. And she had insignificant back pain, but after 1 week, the back pain also released. And I wanted to share my struggles, which I encountered in the beginning of my experience. First is intraoperative bleeding control. Mainly, especially bone bleeding was the main issue which was to struggle for me. Another issue was dural tear. So it's a good advice to have someone experienced one at the initial, at least I think 10-20 cases, to avoid this kind of complications as dural tears. So, but anyway, it shouldn't stop. It shouldn't stop. Let me show this video. How to? This is video of the last patient. The sequence a little bit changed. It doesn't work. Anyway, so we can conclude that PSLD is a good alternative to open decompression, allowing us to achieve adequate decompression while saving the anatomical structures, stability and mobility of the segment. And my message for juniors or for our colleagues who is just starting, don't stop doing and continue learning. And I want to express my deep gratitude to our mentors, to Professor Shatursonov and Dr. Lim Kangtek, for sharing for his rich experience and knowledge. Thank you. Thank you for attention.
Thank you, Dr. Delmore, for your sharing as your nice presentation. Yeah, for nice presentation. Thank you. I'm sorry about it, Dr. Kilmakov and Dr. Imamov. If I made mistake, is now our next presentation is transforaminal discectomy experience in results. Dr. Kilmakov from Russia.
Stay on. Раз. Здравствуйте, уважаемые коллеги. Hello, dear colleagues. I have a mixed presentation. My slides on English, but I'm talk on Russian because it's possibly more people can see what I want to say. I'm from Novosibirsk, work in Travmatology Institute and consultant neurosurgeon in Uzbekistan clinics 5+. Let's start. I talk about я буду говорить о перкутанных эндоскопической декомпрессии при стенозах на поясничном отделе. Стоит отметить, что на данный момент в мире дегенеративные заболевания позвоночника составляют достаточно большую цифру. Так, 39 миллионов страдают спондилолистезом. 103 миллиона человек болеют стенозом позвоночного канала, и 403 миллиона имеют какую-то симптоматическую грыжу межпозвонкового диска. Это представлено в данном метаанализе. Сам стеноз поясничного отдела позвоночника впервые был описан в 1954 году. На тот момент это было непонятное заболевание, которое вызывает непонятные симптомы, и как с ним быть, с этим заболеванием, никто толком не знал. И, наконец, Североамериканское общество спинальных нейрохирургов определило это заболевание, как клинический синдром боли в ягодицах или нижних конечностях, которые могут возникать с болью в спине или без боли в спине, в результате уменьшения пространства для сосудисто-нервных структур в позвоночном канале. Само по себе заболевание стеноз позвоночного канала является одной из последних стадий дегенеративного каскада, который представили в 1982 году данные авторы. Стеноз возникает в результате дегенерации фасетных суставов, они увеличиваются в размере, стремясь достигнуть стабильности для позвоночно-двигательного сегмента, уменьшение в размерах межпозвонкового диска, то есть он становится меньше, уменьшается высота межпозвонкового диска, что в свою очередь приводит к формированию остеофитов. И совместная подобная ситуация вызывает или одноуровневый стеноз, или многоуровневый стеноз у пациента. Поясничный стеноз является достаточно распространенным дегенеративным заболеванием, которое приводит к значительным болевым ощущениям. Люди нередко инвалидизируются, ну и, соответственно, имея такие клинические составляющие данные, пациенты функционально ограничены. Нередко им приходится помогать родственникам, они не могут спать, они часто используют обезболивающие. В общем, это сильно бьет по экономической составляющей семьи, имеющего человека с данной патологией. И распространенность оценивается как 9% среди населения в целом и 47% среди людей 60-летнего возраста. Учитывая тенденцию к старению популяции, человеческой популяции, предполагается, что будет увеличиваться процентное соотношение стеноза во всем мире. То есть данное заболевание приобретает тренд к возрастанию. Если оценивать распространенность данного заболевания по клиническим диагнозам, оно варьирует от 11 до 39%. Как уже говорилось, вернее, как имеется стандарт во всем мире, люди, имеющие боль в поясничном отделе или в голове или где-либо еще, на данный момент сразу же проходят какие-то рентгенологические методы обследования. Зачастую это МРТ. И по данным радиологических обследований распространенность стеноза позвоночника варьирует от 11 до 38%. Данное заболевание успешно и уже давно успешно лечится. Для этого придумано множество разных способов, от начинающейся открытой хирургии, когда выполняли ламиноктомию. В дальнейшем это дело модифицировали с использованием тубулярных ретракторов, маленьких ретракторов, с использованием микроскопа. И, наконец, мы дошли до того времени, когда мы можем использовать эндоскоп. И в данном исследовании проведено сравнение этих методик, где говорится о том, что эндоскоп занимает должное место в методике декомпрессии при данном заболевании. Это наш опыт. С 2021 года по 2023 мы прооперировали 60 пациентов, возраст составил от 45 до 80 лет. Среднее время наблюдения около 25 месяцев. 35 мужчин и 25 женщин. Распределение по уровням. Наиболее частый уровень это был уровень L5, L4, L5, 40 пациентов, L3, 4 и L5, S1. Как уже говорилось, стеноз позвоночного канала, он разделяется на несколько вариантов. В нашем случае встретилось их два. Это центральный стеноз, основная масса пациентов 58, и стеноз латерального кармана. Как правило, стеноз латерального кармана это нечастая патология. Она встречается у пациентов моложе 60 лет и характеризуется разрастанием сустава позвоночного и компрессией и монорадикулярным симптомом. Таких пациентов у нас встретилось на данный момент 2. Всех пациентов мы оценивали по шкалам ВАШ, Освестрии и исхода после операции. Всем пациентам выполнялась рентгенограмма поясничного отдела позвоночника, МРТ, КТ. И не всех пациентов, конечно же, с данной патологией стоит оперировать. Это пациенты, у которых есть боль в ноге, это пациенты, которые должны иметь так называемую перемежающуюся хромоту. Это когда возникает боли по задней поверхности ног или боковым поверхностям ног, усиливающиеся при ходьбе. И после расстояния около 100 метров, как мы себе определили в нашем критериях включения, пациенту требуется отдых, наклон, посидеть, что уменьшает у него боль. Наличие центрального, латерального стеноза и неэффективность консервативного лечения. Не брали на операцию мы пациентов с спондилолистезом второй степени, естественно, не фиксированным, если есть онкологический процесс, инфекция и мягкая грыжа. Использовали мы для определения степени стеноза градацию ШИЗОС. Клинически значимыми критериями стеноза являются грейд B, С и Д. По визуально-аналоговой шкале в результате нашего наблюдения снижение боли в первые сутки после операции как в спине, так и в ногах. По Освестри в течение нашего наблюдения также видно улучшение качества жизни. И по модифицированной шкале МАКНАП мы видим, что большая часть пациентов отметили свое состояние как отлично, в дальнейшем уже хорошо, и меньшая часть удовлетворительно. Это клинический пример. Пациент, боль в ноге 8, в спине 3, ОДИ 27. Видим латеральный стеноз слева. Выполнили контрлатеральную декомпрессию с применением эндоскопа. В послеоперационном периоде декомпрессия достигнута, качество жизни пациента улучшено. Исход заболевания отлично. Пациент с центральным стенозом, ШИЗОС-С, также с выраженным болевым синдромом, выполнена декомпрессия. На этом уровне L4, L5 это был уровень также хорошо, уменьшение болевого синдрома. Из осложнений, которые у нас были, и это, наверное, наиболее самое частое осложнение, которое может быть, это повреждение дурального мешка. У нас таких пациентов было 2-3%, и вот так это можно видеть в эндоскопическую стойку, как это выглядит. То есть мы во время или сверления, или удаления желтой кусачками кересными можем невзначай хватануть кусок дурального мешка. В обоих случаях реоперации с целью герметизации не требовалось, ликварей не было. Также стоит отметить, что полная эндоскопическая интраламинарная декомпрессия показывает, что все процедуры открытой декомпрессии могут быть полностью заменены однопортовым эндоскопическим лечением. Также с развитием методов и инструментов эндоскопической хирургии позвоночника прежние противопоказания, которые раньше мы думали, что мы не можем или тут нам не надо этого делать, они наоборот стали показаниями для проведения эндоскопической хирургии, полной эндоскопической хирургии. На данный момент очень широкая масса публикаций в сравнении разных методов. В данном случае показан метаанализ сравнения микроскопической декомпрессии и эндоскопической. Оба метода хороши, но полностью эндоскопическая декомпрессия показывает улучшение, более лучшие результаты в отношении контроля боли после операции. То есть пациенты меньше чувствуют болевые ощущения, и раньше они их меньше чувствуют. Данная публикация показывает сравнение монопортового и бипортового эндоскопического лечения. Указано, что при монопортовом, то есть фулл-эндоскопии, более короткое хирургическое время, меньше интраоперационное кровотечение и меньше дней госпитализации. Но при бипортальном, если проводить исследования рентгенологические, видно, что больше резекционное окно получается. Трепанационное окно имеется в виду. То есть больше резекции, больше свободы для дурального мешка. Ну а по качествам жизни, это имеется в виду ваш ОДИ, осложнения, статистически недостоверно, но чуть-чуть более лучше является фулл-эндоскопия униполярная. Благодарю за внимание. Еще раз хотела сказать, что хирургия стенозов позвоночного канала является не самой легкой. То есть это не то, что следует делать в начале своего пути. То есть, как правило, эта хирургия нужна для, вернее, используют хирурги уже с опытом трансфораминального, интраламинарного удаления грыж дисков. И в дальнейшем уже стоит переходить на хирургию стенозов. Спасибо за внимание.
Thank you so much, Dr. Kelmakov. So our next speaker is Dr. Efimov from Russia. His topic is transforaminal discectomy and experience and results.
Dear colleagues, good afternoon. I appreciate the opportunity to make this presentation. My name is Dmitry Efimov and I am neurosurgeon in a clinical hospital number 40 in Ekaterinburg, which is one of the 10 largest neurosurgical centers in Russia. The topic of my report is transforaminal discectomy and our experience. Disc herniation is a prevalent form of degenerative process affecting the lumbar spine worldwide. In some cases, surgical treatment may be necessary. Microdiscectomy is currently considered the gold standard in surgical treatment and is the most common form of surgery for this condition. Endoscopic transforaminal surgery emerged approximately 30 years ago and has been gaining popularity over time. This is particularly evident in the growing number of publications over the last 6 years. Our clinic has only recently adopted this technique approximately 3 years ago. Along with transforaminal discectomy, we also employed an endoscopically assisted microdiscectomy, EasyGo. However, we will not be presented the latter in this report. In the last 2 years, our clinic has treated only 37 patients using transforaminal endoscopic procedures. In all cases, the level of disc herniation was at L4-5. We have sets from both Karl Storz and Richard Wolf companies, both of which enable us to perform transforaminal discectomy endoscopically with equal efficiency. We followed the standard surgical technique for our procedures, which included preoperative planning, intraoperative marking under X-ray control, and the placement of a needle and trocar. Next, we installed the walking port with the ideal position, being when the tube outlet was evenly distributed between the disc and the epidural space, half to half. We then introduced endoscope and performed the discectomy under its control. Complete decompression was confirmed, but verifying the free-floating nerve root endoscopically. The surgery was concluded with meticulous hemostasis control, removal of working port, and the application of a single skin suture. Patients were encouraged to walk immediately after waking up, and they were typically discharged from the hospital on the second day after the operation. All patients underwent routine assessment using Oswestry Disability Index and the Visual Analog Scale before the surgery and during the postoperative period. Follow-up was conducted for at least 1 year in the majority of cases. Allow me to present two cases. Case number one, a 43 years old female who reported intense leg pain, VS age, and had undergone conservative therapy for 6 weeks without any relief. MRI revealed a paramedian disc herniation at the L45 level, resulting in root compression. The preoperative Oswestry Disability Index was 70. A standard transcutaneous transforaminal endoscopic discectomy was performed, and a floating root during endoscopy confirmed complete decompression at the disc level. There was no postoperative MRI as it is not included in the standard of care, and it's performed only when necessary. These patients exhibited positive clinical outcomes, so a post-operative MRI was not required. And the case number two, 36 years old female with leg pain, VS7, and Oswestry Disability Index of 66. The patient underwent conservative therapy for 2 months with no relief. The patient also underwent a standard percutaneous transforaminal endoscopic lumbal discectomy. A follow-up MRI showed a small herniation fragment in the epidural space with a much lower density than the original disc herniation. However, the patient exhibited clinical regression of symptoms. An MRI follow-up was done by the patient at a private clinic, and no pain was reported in the leg. In this case, there was a regression of radicular pain after the surgery. The outcome of our 37 cases, as indicated by the Oswestry score dynamics, is presented on this slide and shows a positive trend. The VAS score also shows a positive outcome, consistent with the Oswestry score results. In 10 cases, patients reported experiencing leg pain of the same intensity after the surgery, 5 in the early postoperative period and 5 in the late postoperative period. In all these cases, MRI was performed, and true recurrence of herniation was found in 6 cases. 4 of these patients were effectively treated with medications, while the other 6 required reoperation with microdiscectomy. We want to emphasize that the first 4 recurrences occurred in our first 20 patients, while the remaining 2 occurred in the next 17. This highlights the important role of the surgeon's learning curve in the effectiveness of these procedures. Among the possible complications such as wound and disc infection, CSF leakage, we encountered neurological deficit in only one case, which was increase in paresis of the muscles innerved by the nerve root. It is important to note that with careful endoscopic control during the operation, there were no signs of damage to the nervous structures in this patient. We considered 2 possible reasons for this. The first is additional temporary compression for the nerve root by the walking tube. The second is a vascular reaction is a response to an additional mechanical effect on the root during decompression. In summary, we can draw the following conclusions from our study. Firstly, we found that transforaminal endoscopic discectomy is a safe and effective minimally invasive treatment for lumbar disc herniation. Our results showed positive outcomes in both the oswestry and VAS scores, indicating improvement in pain and function. However, we also observed a high recurrence rate, which requires additional analysis. Our findings suggest that there is a clear correlation between the frequency of disc herniation recurrence and the surgeon's learning curve. This highlights the importance of proper training and experience when performing these procedures. In terms of complications, we encountered only one case of neurological deficit, which we believe was due to temporary compression of this nerve root by the walking tube or vascular reaction in response to additional mechanical effect during the compression. Overall, we believe that transforaminal endoscopic discectomy is a promising option for the treatment of lumbar disc herniation, but further studies are needed to better understand the factors that contribute to recurrence and optimize outcomes. So thank you for attention, the presentation. I hope you found it informative and useful. Thank you again.
Thank you so much, Dr. Efim. Very nice presentation and for using for your respect in our language. Thank you so much. So we are closing our second session because the lunch time is already started. I kindly invite all speakers and international delegates. For you, we have prepared lunch in the second floor. Hurmatli mehmonlar, sizlarga tashqariga joy qilingan, obed qilishga, bemalol chiqib obed qilishlaringiz mumkin. Soat 2da 3-chi sessiyani boshlaymiz. I kindly invite I kindly ask you we will start from 2 p.m. Our third session.
Where is mine?
Hurmatli hamkasb. Hurmatli hamkasblar, vaqt bo'lib qolibdi. Keyingi sessiyamizni iltimos hamma o'z joylarini egallasin. Dear colleagues, please have your seats. The time for the next session started. Dr. Saidilip is ready. Or you need some time? We can start. Our next presentation is Dr. Saidilip. His topic is interlaminar endoscopic technique.
Hello. Good afternoon, friends. It's a tough time for you to have a postprandial session on interlaminar endoscopic technique. Just my topic is just to revising the basics of endoscopic spine surgery and little about the indications which are going over the horizon, where transforaminal surgery was definitive indication. We are trying to reach it as a definitive indication using PSLD. So as you know, there was a nomenclature by the AO Spine for endoscopic surgery. It is a great initiative now, and slowly endoscopic spine surgery is acceptable by the World Spine Society, NAS and everywhere. So initially all endoscopic surgeries, the basic nomenclature is full endoscopic discectomies, full endoscopic thoracic discectomies, full endoscopic lumbar discectomies, and posterior endoscopic cervical decompressions, posterior endoscopic cervical laminoforaminotomies, then lateral recess decompression. Now it has gone to the stage of stenoscopic fusion, stenoscopic ACDF and stenoscopic jumping fusion techniques. So the evolution of the endoscopic surgery has been mainly because of instrumentation. So we should give big kudos for the new invention by the great teachers. So our forefathers of endoscopic spine surgery has fought for to create new instrumentation. So the journey was just interlaminar endoscopic lumbar discectomy by Professor Rutten. It's slowly gone over to endoscopic lateral recess decompression. So with the invention of the drill bit and all the stuff and the punches and the instrumentation, it has gone to unilateral laminotomy and bilateral decompression. Now it has gone to contralateral endoscopic lumbar foraminotomy, which is my topic, and also fusion. So the evolution is because of the instrumentation, as I was saying. So initially the instrumentation was just a forceps and a small annulus cutter, where they was doing something called ligamentum flavum splitting or cutting technique for a wide laminar windows like L5S1, where transforaminal approach, which was the first generation endoscopic spine surgery, the iliac crest was a big issue. Then the second generation instrumentation was because of the endoscopic burr, the Carrison punches, and slowly the third generation is because of the bigger size of the punches, bigger instrumentation, and of course good way of dealing with the bleed. So initial indications for basic interlaminar technique was just subarticular herniations of L4, L5 and L5S1, and lateral recess stenosis, and foraminal and central stenosis has been now the present indication. The spinal instability was a contraindication, where the severe scoliosis, you expect the anatomy to be disturbed, which you need to see. Now even those kind of cases have been taken up with endoscopic spine surgery with the help of navigation. Previous posterior surgery definitely is a tough indication, where differentiation of the anatomy is disturbed, still where transforaminal surgery plays a very important aspect. And higher lumbar levels was also initially a tough job, because facet knockoff and transforaminal surgeries were safer for higher thoracic disc surgeries. But myelopathy and ossified ligamentum flavum, I think now in PSLD is very good. Even for disc herniations in thoracic surgery, we do something called facet knockoff surgery, facet undermining surgery, where you don't touch the central dura, which is kind of a modified transcambrous approach or a modified transforaminal approach. So these were the basic instrumentations how the PSLD can be done. So initial players, we were trying a lot of instrumentation, we wasted a lot of money. But now the newer generation, the advantage of endoscopic surgery with PSLD scope is the instrumentation is less compared to transforaminal surgery. It is just 2 or 3 punches, 1 dilator and 2 or 3 forceps, and an annulus cutter or a disc forceps, and a nerve retractor and a sleeve. Burr and RF cautery, which is mandatory. So the technique, this is the OT setup, how you going to present and how you going to start. This initially for beginners, the side of herniation is the side of the surgeon's hand, and all the visions, C-arm, X-ray and the image processors, everything to the opposite side. Your scrub nurse stays to the right side or left side depending on the hand of your surgery. This is very important, and this is also important when you're trying to do something called contralateral approach. So this pic has been already shown by one of my close friends, and I think you can see a pic where you do a straight interlaminar decompression, and you see a D picture where you are trying to do a contralateral decompression. So just you do unilateral laminectomy and just tilt the scope, you can see the opposite foramen. This is one of my Bible for my endoscopic spine surgery. It was drawn by my professor Dr. Lim. So whenever I go for a surgery, what kind of approach doesn't matter. This pic is my Bible. So if it's stenosis, I start with the high spinolaminar junction, do high cranial laminotomy, then do flavectomy. And depending upon the lateral recess and amount of disc herniation, I go for the next part is the caudal laminectomy and the facetal depending on the lateral recess. So this is the first 1, 2, 3, 4 steps, the orientation of the traversing and the exiting route. So if you know this picture, half of your job for any kind of endoscopic surgery is going to be easy. Even for doing contralateral approach, the process is same. You start with the high cranial laminotomy, go and remove the foraminal below spinous process ligaments, do contralateral laminotomy and flavectomy, and you can reach the opposite side. So similarly for doing stenosis, you start with high cranial laminotomy, see the edge of the flavum which is attached to the cranial lamina, start splitting it until catch it up, and just like you open surgery, pull it down until where you want to do it. So it's going to be easy. So it's a big trouble while you're doing interlaminar technique using the rivoscope. People were doing flaval, just splitting of flavum or cutting of the flavum. So what happens, the cranial flavum and the caudal flavum are just fragile and they're just floating around. So you tend to waste lot of time taking out small pieces of flavum which is really disturbing your vision, but they do or do not give compression. So high cranial laminotomy will solve the purpose of endoscopic decompression to be more faster. This is one more picture which you know from the basic. So this is how the traversing route and how the exiting route will be there for orientation. The previous picture and this picture will solve the purpose of most of the spine cases. When you are doing any kind of interlaminar technique, whether it's biportal surgery or a uniportal surgery. Of course, position is very much important. I prefer using a Wilson frame. Wilson frame, there is sometimes you unnecessarily remove some amount of cranial lamina or bone which you don't require to do. So good Wilson frame will give good distraction of the laminar window. So sometimes you don't need to do unnecessary bone work. Surgical technique, it depends. My place, I prefer doing it under general anesthesia. Patient is on Jackson or Wilson frame. So sometimes it really doesn't matter, but you see the spinous process are not overlapped. Just a rostrocaudal angulation of 10 to 15 degrees for the lower lumbar levels like L4 and L5S1, so that the orientation of the C-arm is exact. The spinous process doesn't come in the middle of the laminar window. So just a caudal tilt of 10 to 15 degrees will decrease your bone resection, decrease your flaval resection. So you don't tend to see spinous process in the middle, which is not really seen, but because of the image intensifier, it looks like that. These are all small surgical tips to increase your speed of your surgery. And this is one more technique. When you are trying to put a dilator into the space, sometimes you just end on kinking on the cranial lamina. Just if you feel the stenosis is more, just a lift on the head side with the surgical table or something like that will orient the spine lamina in the very straight line. So this will help us to do little amount of bone resection or little amount of surgery. These small pearls of surgery is very helpful when you start your surgery. The technique is same. Dr. Lim is going to talk about it. Though you start with surgical technique starts with the spinolaminar junction identification. So according to me, any good bony landmark is a good identifying point to start your surgery. So it can be a spinolaminar junction or a facet. As Dr. Akrov has told, PSLD is just a joystick in the spine. You start with one bone and you can reach wherever you want. So these are the names of the points which have been discussed as Kim's point, Wu's point, where Wu's point and Kim's point are very useful to know how much you want to remove the SAP for the fusion for doing endo-T-leaf. So after you see the flavum, you do it's for only interlaminar technique. You want to do a lateral recess or lateral disc, you just go do little amount of fascectomy with a drill or a punch. Then enter the epidural space using a Carrison punch or annulus cutter to open the flavum. And resection of the disc, just use the scope or a nerve dilator, nerve retractor to push out the neural elements and do the discectomy. So medialization of the disc elements can be done with there is something called nerve retractor, or you can use, if you are using a smaller scope like Revo, you can use the same sleeve. So of course, extraction of the disc is the surgeon's most highest satisfaction which is possible with this. Don't see about the sister who is watching me. So this is a small thing, percutaneous endoscopic transforaminal lumbar foraminotomy. I want to discuss about it, but one of my friends were talking about it. My gut feeling, because my journey of spine surgery has started from transforaminal surgery to stenosis. When you're doing foraminotomy during transforaminal approach, it's more of ventral fascectomy. Ventral fascectomy, the chance of the facet to be destroyed is almost 60 to 70% compared to the ipsilateral facetal resection. So when you're trying to do foraminotomy, while using transforaminal approach, you try to do something called ventral fascectomy. So the chance of the patient going to listhis is quite high. The advantage of doing endoscopic interlaminar lumbar foraminotomy is, if you can do, I'll be showing in the next slide, you can do something called contralateral approach, where you enter the foramen, you undermine the facet. So you're undermining the facet is just decreasing the thickness of the facet. So your chance of destroying the facetal is quite narrow. So my gut feeling after my transition from interlaminar to transforaminal interlaminar journey, I feel interlaminar contralateral decompression for foraminal stenosis patients are quite comfortable. Even transforaminal, it's comfortable, but if I do ventral fascectomy I don't know how much I do. So if I want to do in transforaminal in the previous stages, I would have done a fusion using transcameron fusion. Complications are same: dural taste, intraoperative bleeding, postoperative hematomas. Bony bleed is the most common trouble, and I follow my master's technique. I use something called cuckoo technique. Just use your Carrison punch. Since it's a cancellous bone, just press the punch towards the bone. Half of your bone bleed chances come down. Even bone wax can be used. Of course, any endoscopic surgery, you feel you have removed so much, but sometimes they end up with reherniation, which is far more bigger than the normal. Scope, yeah, the future is, which sir is going to discuss, PSLD, T-leaf, ACDF, thoracic decompression. The initial limitations for endoscopic surgery was very much poor. Now you can see almost 97.36% of spine surgeries, spine ailments can be dealt with endoscopic spine surgery. This is just my drain if I do these things. So I just check the intraoperative epidural drain. Chance of epidural hematoma is quite less if you put a drain. These are the steps what we do. We start landing on the lamina, remove the soft tissue, drill the sublaminar approach, do the laminotomy, then remove the yellow flavum, detach the flavum. Step 4 is separate the neural elements and retract and do your discectomy. So these are few cases which I have done: cervical, posterior cervical, para-PSLD, cervical surgeries, redo surgeries, stenosis, where patients walk immediately post-operative, just within 1 hour after the surgery. Probably my language is different, you don't know. The patient is telling he has no pain, and I'm asking him again, he's getting angry. Why you want pain? No, I said, I was very conscious, because after shifting from open surgery to endospine surgery, patient saying immediate pain relief is a happiness for the surgeon. So these are different kinds of epidural lipodermosis causing fat causing obstruction and S1 radiculopathy. And I can show you a drill how we used to do laminotomy, discectomy. And there are few things like where we do posterior laminar, I think you can see this. So that's a case of a failed back surgery which has been previous laminectomy has been done probably 6-7 years back, and we try to resect it. So I want to finish up with something called foraminal for something called paraspinal surgery or para PSLD or para UBE is an approach where same. I want to close it. I want to open the second seal. It's not going. Yeah.
Thank you.
No, it's not finished.
Not finished?
Just play this. But he's operating. This is one of my favorite cartoon. It says that outpatient spinal surgery was a myth 10 years back. So we were I have seen Dr. Popotowski operating transforaminal surgery under local. So the patient's girlfriend calls him and says, "Sure, and I'll be home for dinner. I'll ask the doctor to hurry it up." So endoscopic surgery has changed the fear factor in the patients. Just a small, So I just want to talk percutaneous stenoscopic lumbar decompression with paramedian approach for foraminal and extraforaminal lesions. So this is a very big indication because initially transforaminal surgery was the ideal technique for doing foraminal and still the ideal technique for doing foraminal or extraforaminal surgeries. Because foraminal lesions, if it's too below the facet, you need to knock off the facet. If it is compressing the exiting route, it's not easy to go and decompress it. So definitely transforaminal approach was good. Since we are the followers of a great surgeon who is advocating a new type of surgery, we try to overcome this trouble. So by starting a new technique called para PSLD. It was first performed by Dr. Lim. These videos or photographs are of Dr. Lim which he has published. It was same like the normal PSLD, the preparation, the scope and all similar. The instruments were similar. So the procedure was just, I think even Dr. Akraway showed you about the foraminal stenosis which he has done. So the skin incision was, the docking was 7 mm, just parallel to the lateral to the midline. Show the midline and the pedicular lateral line, and just 3 to 4 centimeters out of the mid pedicular line is good enough. So this is a good diagram, the difference between transforaminal surgery and where we tend to dock on the isthmus and SAP. But here we don't dock on this SAP. So if you want to do foraminal decompression, still you are parallel to the stenoscope is parallel to the nerve root. So the chance of you injuring is comparatively less. So transforaminal preparation for percutaneous decompression with the paramedian approach is more advantageous if there is concomitant stenosis. If it is a fresh disc herniation, still I advocate doing transforaminal approach, but it is possible using para PSLD. So the procedure is same. You just check the AP. It is quite oblique. I think you can see Dr. Lim doing it. So he does it and he goes to the, he starts going from the parallel, and you can see there is a decompression. So you can see that he has entered through the para PSLD and entered on the ventral facet of the SAP. Try to decompress the facet through make an incision over the isthmus and the transverse process. Just resect it through the pars, make a small small hole and remove the foraminal ligaments, see the exiting route, and just decompress it. You can do discectomy and also decompression. So this is what you can see: the isthmus, the cephalate, the foramen. The isthmus is removed, the root is seen, and also the thecal sac is also visible. So these are the various foraminal stenosis which our patients have under post-surgery who have undergone para-PSLD. These are the foraminal structures. Rarely you tend to have foraminal arteries, which is definitely a bleeder issue, but these are more common in the higher levels, but not much common in the lower levels. Thank you.
Thank you. Thank you for a nice presentation, Dr. Saidali. I'm pleased to invite our honorable speaker, Dr. Lim Kang Tek, for our next presentation. The topic is multi-level PSLD with single skin entry jumping technique.
Yeah. Okay. Like this. I will use this. Okay, I will talk about the lumbar endoscopic decompression for stenosis and disc. I sleep after the lunch, right? That's my disclose. Right. Okay, you know the very well this the spinal operation for the stenosis and the disc. We are here, so we can do the endoscope surgery with a small skin incision. We can do the everything from the cervical to lumbar, and include the fusion surgery. So I'm so very proud that the spine surgeon in Uzbekistan can do all the pathology using the stenosis. I started the transplant approach in 2000. But some problem because just for discectomy is a very good option, good surgery with the transplant approach. But some patients have, especially in Korea, most patients has we are getting the older, so the aging society. Most of patients has the disc and the foramen. So we need to solve this problem at the same time. Not only the disc, we have to decompression the stenosis. And so only with the endoscope, the transforaminal, we can do discectomy, and but no way to solve the problem inside the canal the decompression. So decompression with the transforaminal, but after then, especially inside our technique, right? We have to sacrifice too much the disc, and after the annulotomy, and after the 3 months later, we can see the collapse of the disc space and the foramen. That's why I think always I thought so it's not it can be the incomplete operation always in case of the patient has the stenosis. So that's why we had to manufacture the new instrument, the new concept with the company. And now we can do it with the endoscope. Post-operative, we can do the transforaminal and the stenosis at the same time, and we can do the fusion surgery with the endoscopy, right? And it's a new concept of the endoscope surgery can be the safety and effectiveness. I will talk about this again. It's more important thing is we can preserve the facet joint and the post-ligament complex. You know, the post-ligament complex is very important to maintain the stability post-operatively. And the cervical region, we can do the posterior decompression in case of hernia disc and the foraminal stenosis. and the spinal canal stenosis with myelopathy. So that's why the total case of the HDF, open HDF in Korea has been decreased because we can do endoscopic decompression in case of the pathology. But central disc and myelopathy is impossible to approach the pathology using posterior approach. So we can do HDF. I will talk about this the second times about endoscopic HDF. And we can do high cervical C1 lesion with endoscopy. For instance, the shoulder tumor C1 lesion. Right? So as the patient have the scoliosis, the patient has the radiculopathy more than the back pain. So what was the operation before? So we have to try to correct this the alignment with the multiple level the fusion surgery. But the patient has only the leg pain, right? So we can do endoscopic decompression to make the tunnel, right? A big tunnel or a small tunnel to pass the nerve structures. It's I think the purpose of endoscope surgery, right? Without actually the patient has the back pain, but the mild back pain, right? Before it's my operation before, right? I have to the multiple level the fusion surgery to correct this scoliosis, and the patient has some junctional problem and again extension. It's an open surgery problem. But like this, if we can do just decompression only, it will be better than this big operation, right? It's I think of the philosophy of endoscope surgery, right? Okay, pass. And to performing the cervical thoracic lumbar, so endoscopic system is important, and some instruments are also very important. Camera system and irrigation and CM and operating table is very important also. So I think the endoscope surgery can be to find the enemy in the narrow space and destroy the pathology with endoscopy in narrow space without damage of any the structures, normal anatomical structures. Right? And it's my endoscope. So, 8 mm out diameter and 5.5 working channel and 10 degree lens angle, and we can use 1 to 35 mm carriage punch and drills. So we can with the same scope we can use the lumbar cervical decompression and HDF and the lumbar fusion surgery also. 8 mm out diameter and 5.5 mm the working channel. Okay, so you know very well this advantage of endoscope surgery. So we can do the local anesthesia and to provide a good visualization because we use the water irrigation always, and the water irrigation will prevent infection. Actually, the infection rate is very rare, and less damage of facet joint and the posterior ligament complex to maintain the postoperative stability. And we can avoid the fusion surgery, right? With a good decompression and the multiple level, multi-pathology lesion decompression is possible. And most of the lumbar surgery include the fusion surgery. We can do the performing surgery under the local anesthesia without the general anesthesia, right? As I mentioned, it's very important the posterior ligament complex to maintain the stability post-operatively. We can preserve this, right? So you know the stenosis tunnel is in a narrow space, but we know how to make the wide space with the instrument with endoscopy, right? So the patient has L34 disc connection, but one surgeon in Korea tried to remove this the disc with the transforaminal, right? But the patient has the stenosis, right, combined region, but the surgeon trying to remove disc has a recurrence because he made the annulotomy, the wide annulotomy, and the too much remove a disc. So it's a recurrence rate, right? But the first we had to decompression first, bilateral decompression, and then we have to remove the disc. It's an emergency. It was an emergency case. So I had to try the decompression, like this bilateral decompression and the discectomy, right? So most of the patient has the narrow space because the facet joint hypertrophy. So if you want to try the decompression with the wider, bigger size of the endoscope, it's very difficult to land the endoscope system on the lamina. So just the 8 millimeter is I think reasonable the size endoscope. It's a basic process, the lumbar canal stenosis, right? We can reach the uppermost ligament flavum first, and then we can remove the ligament flavum, ipsilateral and the contralateral side, right? It's all the total operation time can be less than 20 minutes, just one level bilateral, right? And so one level, right? The preoperative shows, MRI shows L45 the stenosis, and the patient has the body tropism, right? So we can approach left approach the better, the right side to preserve facet joint, right? So left side, and we can do post-operative shows, MRI shows full decompression quite enough, and the X-ray shows also, right? Quite enough without damage of facet joint and no damage of the muscle, right? Yeah. And one level, and CT scan pre and post-operative shows well the preservation of the facet joint. And the two-level stenosis, right? It's a jumping technique. It's 5S, right? Post-operative shows, MRI shows the full decompression, two-level, and the actual MRI shows the quite enough decompression with one skin port, right? Not two, it's one skin port. It's a jumping technique. And the patient have the L45 micro instability, right? So L45 stenosis. Patient has the radiculopathy more than the back pain. So I recommend the decompression only instead of fusion surgery, right? So post-operative, two-level, right? You can do with a jumping technique. And three-level, right? Patient have 3, 4, 4, 5, 3, 3, 4, 4, 5, three-level. And axial view also, right? Post-operative, right? Axial view, and right? Full decompression. And then it's like this. Three-level, so full decompression with one skin port. And the patient can work right after surgery. How to? As you can see, the three-level, but we need to keep the drain each level, right, to prevent the post-operative hematoma. Like this, with one skin port, we can do three-level jumping technique. Right? Patient has 3 grenade. Right? How to? First, we can do L4 middle, and then with the same skin incision, we can do the fasciotomy again, and this like this. So we can do the 3-level decompression with the one skin port. It's a jumping technique, right? And the it's a 4+2 operation. 4+2 operation, right? Patient has a 4-level spinal canal stenosis, and the 2-level the foraminal stenosis. How to? Do you want to perform the fusion surgery 4-level? No, it's the 4+2 operation. First, we can do is 4-level, it's the spinal canal decompression with one skin port, right, like this. And we using the paraspinal approach, transforaminal approach, paraspinal approach, right? We can do foraminal decompression like this, right? So it's so many, 6 drainage. 6, it's 2 means the foraminal decompression. It's 4 drain means 4 level decompression with 1 skin port, right? Post-operative, right? It's just 2 skin incision is enough without fusion surgery, right? So patient have a 6 grenade, right? 6, right? 6 grenade. It's a 4+2. And the patient has L5S1 and 34. So we can do the same with the 1 skin port. We can do 2 level, right? The first. So jumping up, jumping down, we can do 2 level decompression, right? And so the transforaminal approach, right? The 1 level approach, right? 1 level decompression. And the post-operative, you can see the cut SAP. And the 2 level decompression, right? With a 1 skin port, we can do 2 level foraminal decompression, right? So the jumping technique also. And some patient has the double crash, right? Patient have L5 root L5 root the symptom, but MRI shows L45 the central the canal stenosis and L5S1 right side foraminal stenosis. It's a double crash. You don't miss this. You can make the misdiagnosis, right? The most of the doctor trying to only remove the L45, but actually the patient has L45 spinal canal stenosis and the foraminal stenosis 5%, right? We had to solve the problem at the same time, right? The first L45, the intraabdominal approach, bilateral decompression, and then jumping down L5S1. A patient has a high iliac crest, so I try to for L5S1 foraminal decompression is the contralateral approach inside out, right? From inside to outside. So with a 1 skin port, L45 decompression, bilateral, and then jumping down L5S1 intraabdominal, and then we can decompress L5S1 contralateral approach, right? So with a 1 skin port, we can L45 2 root and 5S1 2 root, and then the foraminal, right? 5 root with a 1 skin port decompression enough. And this morning, the Dr. Akoro said that this the bilateral, in case of bilateral, the foraminal stenosis, in Korea, it's a good indication for the fusion surgery, right? But yes, I do like this, like the Akoro. The first, the paraspinal approach, foraminal approach, we can do the foraminal decompression, the ipsilateral, and then contralateral side. So we can do the bilateral, the decompression with the endoscopy. We can avoid the fusion surgery, right? So in case of revision, right? Revision is microscope revision. The operation is very difficult to distinguish another structures, but the endoscopy is it provides the clear surgical view. We can divide, we can dissect the structures, or the visualizes. We can decompression with endoscopy. So compared to microscope, in case of revision, is better using the endoscope surgery. And we can apply this the endosurgery for the thoracic OLF, right? Pre and post operative like this. So it's very useful for the spinal, the canals, and the foraminal stenosis, using the endoscopy. In case of Duratiel, right? It's Duratiel is the very scale moment every for the surgeon, right? But we can seal the dura with a taco seal, the fibrin cylinder patch. But if you want to I don't know how to try suture. If you want to learn the suture, ask the Dr. Akor. It's the best surgeon, I think. And in case of bone bleeding, right? Bone bleeding, so we can compress the cancellous bone with the case sponge firmly. We can stop the bleeding, the bone bleeding, right? Again, press firmly the cancellous bone with the case sponge. Can you stop, right? Okay. In conclusion, I think the endoscope surgery is not option now. It's a must. Endoscope surgery is a must, not an option in spine field now. So for the young surgeon, it's impossible to survive as the spine surgeon without endoscope surgery in the near future. That's why you should learn the endoscope surgery. I will talk about cervical posterior decompression and anterior HDF and lumbar fusion the next time, right? So there are so many. Is it working? Your choice. What is your choice?
Is this good or bad?
Well. Okay, thank you.
Thank you, Dr. Lim. Thank you. Thank you, Dr. Lim, for meaningful presentation, for amazing presentation. The next presenter is Dr. Baban from Mongolia. Please, Dr. Baban. His topic about clinical and radiological outcomes of PSCD.
Good afternoon, everyone. I am from Mongolia, and my name is Norbek Baban. My hospital is in Mongolia, specialized spine hospital, especially endoscopic surgeries. And first of all, I would like to say to organizing committees, thank you, such good conference. So today's my topic is clinical and radiological outcome of PSCD. So I will focus on mainly in peroneal stenosis of cervical. So we all knows that PSCD is good outcome, but sometimes in severe case we can meet after numbness after PSCD. So today I am focused on cervical peroneal stenosis. So unfortunately, sometimes we can meet complications after PSCD. Pain can continue 9% of, and revision rate almost 4, and we can meet palsy. In my practice, I not meet that such complications, but I meet several times numbness after decompression. So in severe case, recently I am doing pedicle remove of some part of pedicle, and so it's called partial pedicultomy. So this is picture is after surgeries. You can see remove of some part of pedicle. So you can see in this video how to drill out of pedicle on the cervical, and you can use also different tip, protecting tip, nerve roots. In this video you can see nerve root, and there is axilla, and you can drill out pedicle. So actually I do in following 4 cases, pedicultomy and severe foraminal stenosis case, and you can see in this video severe swollen nerve root, and if you put some punch after surgeries, patient can feel some numbness pain. And severe adhesion case, sometimes coronal tilting, I do pedicultomy. So from this video we can see naturally stage of degeneration. So if we see in detail, there is changing vertebral height of disc, and there is changing of anterior and posterior disc height, and kyphotic changes. So some doctors and some researchers believe that after some remove of some part of pedicle, it can be rapid degeneration and it can be deformity. So that's why we studied that situation. We collected of 40 case data of 40 case. We divided 2 groups. One is foraminotomy, 20 case, without pedicultomy, foraminotomy. 20 cases foraminotomy and pediculotomy. And we collected data numbness and foraminal area and cervical curvature index, and we follow up 1 year, and we did statistically some difference. So what is cervical curvature index? This is A is anterior, B is posterior, and C is body. And we also calculated post-op and pre-op foraminal area. And we collected also clinically numbness clinically, and the result was like that. Foraminal area with and without pedicultomy was quite different. Pedicultomy was big, and after following 1 year, foraminal still keeping shape, and second result was numbness. Pedicultomy group was 30% of numbness. Without pedicultomy group was 30%. With pedicultomy group was 10%. And after 1 year follow-up, 5% and 10%. So p-value was like statistically significant. So you can see from these graphics, there is mean cervical curvature index and mean foraminal area is really difficult. 1 year and postoperative 1 year follow-up. So conclusion finally, the cervical spine surgery without pedicultomy associated with improvement foraminal area and the cervical curvature index, post-surgical 1 year follow-up on CT scan, and clinically also it was good. So if patients have severe foraminal stenosis, next choice is pedicultomy. Thank you so much.
Thank you, Dr. Baban, for a nice presentation. Dr. Lim, please, for the next presentation. The topic of the next presentation of Dr. Lim Kangtek is posterior stethoscopic cervical decompression, a technical note.
Okay, hello again. So I will talk about the endoscopic spine surgery for the cervical lesion. As the endoscopic spine surgeon in the Uzbekistan and the Kyrgyzstan. So I'm so proud that they can do the endoscopic surgery now. The 10 more than, right? 10? 10 endoscopic surgery. So again, disclose as my disclose. And with the endoscopic the system, we can do the in case of the foraminal, the disc or the stenosis, and right, and HDF and high cervical lesion also. Before introduction of endoscopic surgery for the cervical, we can do the big operation HDF and then the laminoplasty, big open surgery. So they have some problem, the instability post-operatively and the kyphosis, because we had to make a damage the post-ligament complex. So it's very important post-ligament complex to maintain the stability. So it's post-ligament complex is like the bowstring in the bow. So endoscopic surgery can save posterior muscle and connective tissue. And strategy for the stenosis and disc is different, because in case of disc, the fragment will push the nerve structure to upside, so we can approach the axial approach. But the stenosis, the narrow space, we can approach first the facet approach. The first remove the facet and we can make a space, and we can decompression hold the root. So it's a different approach in case of the herniated disc and the stenosis. Right, so always the root and the frame is just located just below the facet joint, and the sensory root located just below the facet joint. First, try the decompression facet joint first, and then we can decompress the external portion. It's a strategy, right? The landing point is the medial border of lateral mass, and first we have to laminectomy, and upper and lower, and we can reach make the space with the decompression, right, like this. And so it's a good indication for the beginning of the first the foraminal, the one side the stenosis with the endoscopy. Right? As a process, first the landing on the medial border lateral mass. You can do the laminectomy, and in case of C4, 5 or 6, C6 and C5, it's a void point, and we can remove some of the facet to make a space, because a narrow space is very difficult to handle the instrument in narrow space. So we can make we have to make the rooms for handle the instrument. And finally, you can see the disc space, annulus, right? And you can see the motor root is ventral, and the dorsal is the sensory root. Sometimes it will make the mistake that we can damage about the motor root. It looks like similar like the disc and motor root. So you should be careful not to damage the motor root. So it's a strategy in case of stenosis and disc. First, the stenosis, just unroofing is enough. Right? Root decompression, like the narrow coordinate canal. Right? But in case of the disc, we need to get the pediculotomy to make a space, like the wide Suez canal, right? It's very important. Like this. And it's very important. It's a two-hand surgery. So it's my elbow is touch the patient back to fix my the arm, and you can see the left thumb can hold the calcium punch, and then like this, right? So it's a two-handed surgery, right? Not one-handed surgery. It's very important to prevent the damage of a nervous structure. A two-handed surgery, right? It is possible in uniportal endoscope surgery. They should be careful not to damage the spinal cord during the operation. And how to solve the problem in case of multiple level? What is your option like this, the multiple level, the stenosis? The most of the spine doctor trying to performing the laminoplasty post-operative, right? So it's my case, 3 level. 3 level buckling of ligament flavum, central, the canal stenosis, axial MRI shows central canal stenosis. In the post-operatively, with one skin port, we can do the full decompression at 3 level with one skin port, right? It's 3, 4, 4, 5, 5 or 6. How to? It's a sliding technique. Not it's as I told about the jumping technique, the Lumba, right? It's a sliding technique. It's like this, right? 3 level. We can avoid the big open surgery, laminoplasty. Right? It's possible the full decompression. Right? We can avoid the laminoplasty, right? You can understand the musician is a Paganini, right? Paganini, violinist, the create innovative method is multiple stopping. It's multiple. Yet we can play music multiple at the same time. It was innovative. It's shocking. And the left hand pizzicato, right? It's an innovative method. So it's the same like the technique, how to performing the 4 level, multiple level with one skin port. We can avoid, right, laminoplasty. The 4 level stenosis post-operatively, okay. It's a sliding technique, right? First, it's like this. Okay. No. Okay. 5 or 6, 6, 7, C4, 5, right? It's a sliding technique. So the post-operative MRI shows full decompression of the full level with the endoscopic multiple level technique. Post-operative, the X-ray, the 2 year later follow shows no any the kyphosis, right? Very stable. And the axial, the MRI shows the decompression is quite enough for 4 level. Right? So one skin port we can do the 4 level, right? And in case of myelopathy, it's very important to check out the dynamic MRI extension, the flexion, to know the what is the main cause of pathology. Flexion, extension, flexion is very different, right? But in case of myelopathy, so you can see the huge the the calcified disc in front, in the anterior side, but it's very difficult to remove this using the posterior approach. How to, right? And CT scan shows the calcified lesion. CT scan like this. It's difficult to the decompression using posterior approach. How to? I tried. My plan was anterior approach, right? First, the cut the anterior, the hypertrophic osteophyte, and the posterior also remove like this, and the cage insertion like this, anterior approach. So always the strategy for the pathology should be the depend on location. So in case of just a canal stenosis and the foraminal stenosis, we can do the posterior approach is possible, but anterior pathology is impossible to solve the problem using the posterior approach, right? So anterior approach, we have to anterior approach with a calcium punch, we can remove this the calcified lesion, right? Post-operative shows decompression, enough, and the CT scan shows the removal of calcified lesion is complete. Yes. And our patient have the anterior calcified disc and the posterior thickening of ligament flavum. It's a very old 80, right? 80 the male patient. So the patient has 34 myelopathy, and the AP diameter the less than the 5 millimeter, very narrow the AP diameter, and the post-operative MRI shows posterior decompression and anterior decompression also, and the axial view is you can make a wider space spinal canal. I performed the first posterior decompression first, and then I perform anterior decompression and insert the cage HDF. Right? You can see the cage, 8 millimeter cage, and you can see the drain, anterior drain and posterior drain. So it's the video clip after the posterior decompression. You can see the spinal cord, ipsilateral and the contralateral decompression, full decompression enough. And it's the before the implantation, anterior approach, after the removal of the ligament flavum and the posterior ligament, and you can see the dural pulsation, right? And see one lesion. So we are familiar this the operation in case of shoulder tumor C1 lesion and the instability. We are used to this operation, the first decompression, laminectomy and the fusion surgery. I had the C2 root compression with the rheumatoid arthritis. No, before operation, no instability, so I tried the decompression with endoscopy. C2 root decompression. It's a process. C2 root using the drill, you can decompress C2 root and we can remove a panus complex. It's a C2 root. Right? But before the operation, we need to check out the CT angiogram to know the course of the vertebral artery. Yes, right? The same. The Pesca-Jones sub-occipital the triangle is the landing point. Same like the open surgery. It's a C1 to myelopathy. C1 to, right? Then C1 to no instability preoperatively, and the AP diameter is very narrow space. So I tried the post-operative, right? Pre and post-operative. Pre and post-operative. You can apply the endoscopy for C1 lesion. But before operation, I worry about what are the effect on brain because there was no any the reference about this. But fortunately, there was no any problem in the brain. So with a new endoscope, I think we can do all the performing the pathology for the spine with the endoscopy. So in conclusion, the Paganini practice violin more than 10 hours daily, Paganini, right? To get the new technique. So learning endoscope surgery for the cervical pathology is not always easy for the surgeon to be the best, but it will be very rewarding and worthwhile. Okay. Thank you so much.
Thank you, Dr. Lim, for amazing presentation. Next speaker is Dr. Ahror, please. The topic is suturing technique in case of dural tears during endoscopic surgery.
Good afternoon. I think every spine surgeon, endoscopic spine surgeon in own practice have dural damage. If we one second. Yes. During surgery, because mainly is old generation mainly ligamentum flavum mainly sometimes calcified. With calcification, ligamentum flavum is adhesion with a dura. During removing ligamentum flavum, we can, if you carefully remove, you can save dura, but sometimes very adhesions there is, you can open, you can damage dura. If a small damage, you can use Surgicel for closing. But sometimes what I have is in my practice I had big dural damage. I put Surgicel, but after surgery, anesthesia, when anesthesia was gone, patient was having severe pain again. Second time I took surgery for suturing. Yeah, if what we can use for closing dural tear mainly is I use this Surgicel because Surgicel is available and is low price. But Tachocel, you can use Tachocel, but in my country, Tachocel is most costly. That's why I cannot use. If dural tear, we have the 3-4 dural tear. Why it's not? Yeah. We have is such a big, more than 1 centimeter dural tear. There is is coming out is nerve roots. That's why like this dural tear we have to close. Sometimes there is question, do we need open surgery for closing dural tear? No, if you can do by endoscopic sutures. We don't need in open surgery. Suturing instruments and materials. You don't need special instruments for putting sutures. You can take this polypropylene 6-0, and you can use. I used that cases drainage tube for nut pusher. If you don't have drainage, you can use also simple scissors for nut pusher, or hook. With hook also you can use like in nut pusher. What we can do first is this needle. First is 6-0 needle. Like this, we cannot put inside through by the working channel. That's why in needle we make a little straight posterior, which is a connecting part of wire. We can make straight with forceps. Put inside is easy. Sword is like this. First, outside in technique we have to do from medial part dura. Outside in technique we can put this needle, and second is inside out technique. Yeah, its maneuvering is difficult, little, no, but can do. Four steps when you pull out the needle. From inside to outside, we can throw the foramen. There is small foramen in the drainage. Through the foramen, we can from inside to outside we can pull out this needle, and outside this working channel, we have to make knot. We have to make knot, and this 5 step, and 6 step is with the drainage. We can push it down, push it inside our nut. Yeah, how is this under vision? You need one assistant to hold the scopes. This is the noise of owner of hospital. Yeah, but this I completely close it. But this when I cut this wire, my suture little lose it. If you can see here is a gap. But this gap still is coming out these sutures from caudal side. What I use surgical for closing that gap. Yeah, it's a surgical. You put surgical, and you can use a dissector. Put the inside between the dura. Yeah. That's it. In caudal part also, like same technique. Pressure? You mean water pressure? Is natural flow?
Natural flow, no pump. See, is now is completely closed, both cranial and caudal part. Thank you so much.
Thank you for amazing presentation, Dr. Akor. Our next speaker is Dr. Elmer. Please, Dr. Elmer. So topic is decision making for endoscopic decompression in high cervical spinal cord compression.
All right. Thank you very much for that very entertaining video, Dr. Akor. So I'll be discussing 2 cases. I have no disclosure, except for this, that we had the first spinal stethoscopic surgery conference in 2021. It's an online event. So we are very happy now that we can attend conferences and meet people face to face. This afternoon, I'm going to share with you 2 very important cases that I had to use all my brain cells to solve the cases and help the patient. So case 1 is C2-3 disc hernia, and case 2 is Pinus formation with ligament hypertrophy in C1-2. The concept of decision making is very important in this. That's why I use the term, I use that in my title. The decision is derived from decider, which means a cutting away or cutting off of different alternatives and options. And to decide means to come to a conclusion. The requirements to arrive at the decision is to have an identified problem, to be able to have a correct decision, and the correct decision is based on the accuracy of the information that you have and your ability to discern and trace whatever and filter out the not important information. And then most importantly is to effectively communicate your decision to your patients' relatives, the hospital staff. And then you have to have a multidisciplinary approach and participation. Surgery now, especially neurosurgery, especially spine surgery, is not a single surgeon approach. It's a multidisciplinary team that should have a best outcome. So this is the steps. You have identified problem, you search for alternatives, and then you evaluate alternatives. Then you choose your alternatives, and maybe you have a first choice, and then maybe a backup plan, and then you do your action, and then you operate and evaluate the results. For the first case, 49-year-old female, 2 months prior complained of sudden dizziness with tingling numbness from the neck down to the feet upon lifting packs of relief goods. The numbness progressed to inability to walk and the patient developed electric shock-like sensation from the neck down associated with the moving of the head. There's progression to inability to move right and left, right side. The hand grip is 1/5, and there's no functional motor on the left, and there's generalized decreased sensory, and this prompted the MRI. And the patient also has a right-sided upper extremity and left-sided left lower extremity paresis from before, during her childhood when she had poliomyelitis. But she's a fully functional person.
Peculiar in this case as well is that the patient has a history of thyroid cancer with a modified radical neck dissection. The preoperative status, you can see that the right biceps is only 0 to 1/5. The hand grip is 1/5. Even on the left, it's not really functional, only 3 and 2/5. There's bilateral Hoffman's. The sensory is 30% down. And, but the rectal exam and the motor and sensory is intact for the rectal exam. Here's the preoperative MRI. You can see the cord edema at C2-3 level. And you can see the very compressed spinal cord, cervical spinal cord at that level. So how can we solve this? The incidence of high cervical spinal cord, this herniation is very, very small, and it's only 0.28%. The approaches has been elucidated in cadaveric studies. I searched internet, I searched PubMed, and all the other literature sites, and can only find 3 published operative cases. So how to evaluate my options? What can I do for the approach? Can a transoral approach be applicable? It's a direct approach to the C2-3 level. I can do transcorporeal, transoral, but there is no literature available on that, except in transcorporeal C3, there's a technical report from South Korea. Should I do open or endoscopic? And should I do a fragmentectomy or a full discectomy, like a fusion surgery? So these are all the questions I had. This is the submandibular open approach, and I showed this to the patient as one of the options, and the patient and the relative said, "This is not for me." And Russo et al. In 2009 did a cadaveric study of the approach at the C2-3 level, the submandibular approach, very clearly that we have to master a lot of anatomy just to go to this level anteriorly in an open technique. We can also have the transoral approach, open. You can open the mandible, just like the Alien movie, that the mandible opens up and you get your proboscis for eating your humans. So this is a maximal invasive approach. So I chose the transoral approach using endoscopic spine endoscopy, and I underwent a peer review process. I had a discussion with my mentors in Korea, especially Dr. Im Kang-tek, and I had a discussion with my mentors as well in the Philippines. So I had to do informed consent, and I had to ask the Hospital Ethics and Review Board for approval to do the procedure. So these are the preparations I made. I had to measure if the endoscope from the incisor will reach up to that spinal canal. And this is the step-by-step procedure. I always divide the procedure into approach stage, endoscopic stage, and the endpoint stage. So you have the preoperative. After positioning, you create a 1 to 1.5 incision on the mucosa, midline over the C2 body, and then you duct the reamer, and then you do reaming, and then drilling of the transcorporeal tunnel on C2, and then the endoscopic stage in brown is using C-arm. You confirm the surgical site. You do the fragmentectomy, very small fragment is removed, and then you clear the annulus, and they identify the PLL, posterior longitudinal ligament. And you do hemostasis
and closure of the mucosa for the endpoint. This is the positioning of the patient. I used the two nasogastric tubes. One nasogastric tube for the posterior pharyngeal wall to suction and the saline irrigation, and the second nasogastric tube for feeding post-operatively. This is the position of the patient in Mayfield with the two nasogastric tubes, and using the Dingman retractor to approach and open the C2 pharynx. That's the operative workflow. That's the initial incision above the body of the C2, the docking of the working sleeve, and then you can see the reamer over there. I'm starting reaming at this point. So this is the reamer. The reamer now you can see at the middle of the C2 body and at the end point. This is the canal. You can see the reamer is actually already in the canal, but take note that there's a herniation. That's why the reamer is just on the herniation, not on the spinal cord. So this is a video. I'm going to go through it very quickly. This is the posterior annulus, and then the disc. You can see removing of the disc, and then basically very easy, like picking apples. And then I have to remove the annulus building up over that area. So this is the annulus further removed, and underneath you can see a thin layer of posterior longitudinal ligament, and you can probably see some fiber of the spinal cord. I made several slides, still shots for the audience who cannot see the whole video because of the time limitation. So here we can get the disc hernia. This is a very important slide because this is the endpoint. You can see here the C3 end plate. This is the remnant annulus that you removed, the lateral wall of the bone tunnel, the thin layer of PLL, and the C2 end plate. And this slide is also important that you can see the edges of the working sleeve is around 9 millimeter or 10 millimeter. So this is around 5 to 6 millimeter bone tunnel. The endpoint can show you the annulus. There's 360 evaluation of the surgical field and strict hemostasis during the cutting of the mucosa, during the surgery, and then after the surgery. This is the preoperative MRI, and then you can see the postoperative MRI. The 3D reconstruction after the surgery, you can see the opening of the anterior part of the body, the posterior part of the body, and the bone tunnel. And after 2 weeks, the patient was discharged after 3 days. After 2 weeks, there's significant improvement of the motor from 1/5 to 4/5, 2/5 to 5/5, and the rest has improved, even the sensory. This is a pre-op MRI, 3 days post-operative, and 6 months post-operative MRI. And the bone has healed after 1 month, and then this is 6 months post-operatively, the bone is back to normal. Now we go to the second case, 61-year-old female, type 2 diabetes, controlled hypertension, no history of trauma. The main symptoms is 10 years of recurring joint pains, especially in the cervical area and shoulders. There's a long time on and off pain on the and numbness on the left shoulder. And then 1 year prior to admission, the pain persisted until a rheumatologist treated the patient. which afforded temporary relief with the medical management. So the continued rehab, but it's failed. And then the patient was seen by a spine specialist, and MRI was requested. It revealed the C1-2 canal stenosis with pannus formation. So, well, luckily the patient has no significant sensory and motor deficit at that time. And this is the CT scan of the patient. And that's the very, very tight C1-2 level. It's almost 2 millimeter distance for the cervical cord. Dynamic X-rays is intact. And 3D CT scan revealed os odontoideum in this patient. So there's fusion of the atlanto-occipital junction and the fusion as well of the atlanto-axial junction. So in this patient, autofusion developed, so the body really tries to heal itself. And you can see in the 3D CT reconstruction that the C1 has fused with the occiput. The condyle, occipital condyle, has fused with the atlanto-occipital junction, and the atlanto-axial junction has fused as well. So what should I do? I decided to go first for the decompression of the C1-2 ligament. What's the cause of the symptom? It's probably a foraminal stenosis or a arthritis. So this is what I did. I docked on C2, spinolaminar junction, and then I drilled anterior part of the C2 or the cranial part of C2 and drilled the caudal part of C1 and then removed the ligament. A simple procedure, and that's what I did. So here are the still images of the procedure. This is the C2 body, and then drilling of the C2 body, the C2 lamina, and then I tried to remove and retract the flavum, ligamentum flavum. Now this is C1 lamina or arch, posterior arch, drilling of the posterior arch of C1 and removal, punch, using Carrison punch, removal of the lamina, posterior part of the arch of C1. And that's removing the ligamentum flavum. And this is the endpoint, even up to the contralateral side. So I used fiber optic intubation during an induction. Intraoperative neurophysiologic monitoring is important. And the saline irrigation is by gravity so as not to increase the pressure into the cervical spinal cord. And very important is to lower the blood pressure. Even for lumbar, thoracic, and cervical surgeries, always I lower the blood pressure, systolic blood pressure to 90 to decrease the chance for bleeding. So this is the preoperative marking and the postoperative suturing of the skin. This is pre-op, 1.2 millimeter, and post-op, 6 millimeter, pre-op and post-op MRI. The patient is very happy and went to Hong Kong 2 weeks ago to have a vacation. For my take-home message, we always individualize the approach for our patients. Careful evaluation of the history and physical examination and radiology will determine the indications and appropriate procedure for each patient. Do not rush diagnosis and the surgical plan. It's okay to tell the patient, I'm going to study your case, give me some time. And posterior stenoscopic cervical decompression is a viable option in this case and these two cases. In a straightforward procedure, it will not injure the built-in stabilizers of the occipito-cervical junction. Thank you very much for your kind attention.
Thank you.
Before I stop, this is very important. From where I trained, I went into several cadaveric studies. The dead always teach the living. So thank you once again.
Thank you for amazing educative presentation, Dr. Amir. Our next presenter, our teacher again. Please, Dr. Lim. The topic of this presentation is uniportal endoscopic T-leaf.
Okay, I will talk about the final, the full endoscopic lumbar intervertebral fusion. Okay. So it's the lumbar intervertebral fusion is very popular in Korea now. So using endoscope, the uniportal and the biportal also. So I'm uniportal surgeon. How to let you know how to performing the fusion surgery. So with under the local anesthesia, is fusion surgery is possible. So in case of a motion caused back pain, we have to fusion. It's a structural problem. It's a very beautiful jazz music, but it's good beautiful jazz music is very important. The collaboration of piano, double bass, drum, trumpet, flute. So same like the endoscope surgery. So we can use the same endoscope. We can use 1, 2, 3, 5 charismatic punch and the drill for endoscope the fusion. And endoscope and the instrument and the camera system is also important. And irrigation and the system monitor, so it's the harmony is very important. But the endoscope fusion, we need to consider the fusion bed, how to make a fusion bed area, and the endoplate preparation, the bone graft, right? So it's like same open surgery, open the fusion surgery. So and we need to consider the segmental lumbar lordosis post-operative, and ASD, and something like post-operative back pain. So under the epidural anesthesia, we can do the endoscopic fusion surgery. And the first skin incision, they should make the small 1.5 centimeter from the 3 centimeter from the midline. If the patient has L4-5 the instability, and from the midline, the 3 centimeter is we have to make the skin incision. And in case the female patient have the L4-5 spondylolisthesis, and the patient has the rheumatoid factor, the positive, and have the kidney problem, and the post-operative, and from the centimeter, 3 centimeter from midline, we can make the skin incision, and as we can do total facetectomy is very important, bilateral, not unilateral, right? The first with total facetectomy ipsilateral, we can expose L4 root, axial root, and then L5 traverse root at the same time, right? It's a direct decompression. I like direct decompression. And then we can do contralateral approach, contralateral facetectomy. We had to bilateral facetectomy. Why? It's good for surgical correction, right? Reduction. And then we can insert the endoscope system in the disc space to remove a disc as much as we can. Right? It's the small skin incision. Right? With one skin port, we can do bilateral facetectomy and the discectomy, cage insertion, the pedicle screw, and we had to make the 3 additional the skin incision for the pedicle screw. So total operation time, the less than the 2 hours with a small skin incision, right? So as I mentioned, first we can do the bilateral facetectomy, and then we can do the discectomy, and then we can do the bone graft with endoscope, and then we can insert the cage. And compared to the open surgery, we can make the wider the fusion bed area, because the endoscopy can reach to opposite side for the discectomy. You can make more the fusion bed. Endoscope can reach to opposite side like this. So most I think the 40 and 50% bone graft area we can make it. And the cage, the midline the placement with the DBM. Okay. See allobone graft. How is the correction, the post-operative. Right? So after the removal of the disc, you can make a space, and then you can do allobone graft, and you can insert the cage in the midline. Look at this. Or to correct the surgical reduction, we can place this cage anterior, right, to make to correct the surgical reduction, right? Sometimes if we insert too much the allobone, sometimes it leaks to after a space. You should be careful. Allobone graft, right? And after facetectomy, we can make a space, big space, right? Wide space. And first, under the endoscope view, first we can insert the cage holder first, and then we can set the cage. So the video is allobone graft, right? Allobone graft, and we can push the nerve structure to the opposite side with a walking sleeve. It's a midline, and then you can put K-wire, right? K-wire will act as the retract to prevent the damage of the nerve damage. And then you can set the cage, and then you can insert cage under the endoscope view. You can see the K-wire, right? K-wire. It's real, right? The endoscopic fusion surgery under the endoscope view. Some doctor, the third, insist using just only the C-arm view, right? Can insert the cage. It's not endoscopic the tulip. It's just using endoscope. They try to the facetectomy and the discectomy, and then the insertion of a cage that they had under just only the C-arm blind operation, just not real the endoscopic, the fusion surgery. It's real endoscopic fusion surgery under the endoscopic view, right? Okay, finally you can see axillary portion, L5 root. Okay, it's sorry. Okay. Anyway, so I use the 3D printed porous titanium cage. It's created also the conductive of the surface, so the bone leading to bone ingress, outgrowth. So the fusion rate is very good. And yes, this patient has the post-operative MRI shows the quite enough the correction of the lordosis with a small skin lesion, and surgical reduction is a very nice on every case because I performed the bilateral the facetectomy, right? cage. So how to insert cage the anterior? The first we can insert the cage and then we can turn cage inside. We can make the lumbar lordosis. Right? Okay. Reduction is very good. And then, so we perform the bilateral facetectomy. The complete reduction will increase the contact area alignment, then the incomplete the reduction. So with a small skin incision, we can do bilateral facectomy and discectomy, album graft implantation. Right? So as I mentioned, full endoscope. We can use discectomy and we can use a shaver and album graft cage insertion, right? Under the endoscope view. It can be the real, the endoscopic, the fusion surgery, right? Okay. Can use endoscope system. The back pain is better than the mini open surgery because we don't the damage of the muscle and the post-ligament complex, right? And the cross-sectional area post-operatively, and the disc height, all the parameter is good, better than the open surgery, because we can make the wider space bone graft area. It's my paper, my paper about comparative study on bone graft area fusion rate in unilateral transperineal the interval fusion between endoscope and the mini open surgery. So endoscope surgery, fusion surgery, and do not damage the post-ligament complex, very important. We are the Homo endoscopicus. We can use endoscope, right, instead of some instrument. Okay, the endoscope fusion has some of the advantage, minimal invasive, and we can the bone graft area, and the fusion rate and the lordosis is better than the open surgery. The infection rate is very rare because we can use the water irrigation. The patient can walk the next day because we didn't damage any anatomical structures. Thank you so much.
Thank you, Dr. Lim, for great educative lecture. Thank you, Dr. Lim. Next presentation is Dr. Eshwar from India. The topic is expanding the horizons of spine endoscopy.
Very good afternoon to all. Myself, Dr. Ishwar. I am from coastal town of India, Visakhapatnam. Already all the pioneers have discussed most of the things about endoscopy. I'm just telling you the some different cases in the endoscopy. So all these indications were already dealt by all the pioneers who have already discussed, like listhesis, cervical disc, lumbar canal stenosis, migrated disc. So I will discuss beyond the degenerative pathology, like one is discal cyst, another is vertebral body metastasis. Here is the first case. 29, a young male who is a heavy machinery operator. He has right leg pain for the last 3 months. Examination shows SLRT positive, but there are no focal neurological deficits. So this is his MRI showing a cystic lesion at alpha S1 disc level, and apparently it has a connection with the disc here. There was a history of trauma, mild trauma 1 month back, 3 months back. So here are the treatment options I discussed with the patient. One is microscopic laminar foraminectomy and excision of the cyst. Another is endoscopic excision of the cyst, CT guided puncture and root block. All these things were already tried and they were already documented in the literature. So here is the small operative video. After laminectomy and flavectomy, this is the epidural fat I am removing. And after that, there you can see a semi-translucent cyst stretching the root and the theca. The wall of the cyst is having capillaries. So I am dissecting the cyst from the theca, dura. It has no connection with the dura or root. So it's not the synovial cyst. Once I puncture the cyst, there is old clots came out of the cyst. So these are the old clots from the cystic wall. After that, I excised the cyst and I did the annuloplasty, and patient is relieved of his pain. Here is the just another theca and the cyst, and after decompression, the root is medialized here. So histopath confirms the same, the discal cyst, and patient returned to his work after 2 weeks. Here is the second case. She is a 62 years old lady with a severe back pain and bilateral radiculopathy. There are no motor deficits. MRI shows multiple vertebral body lesions, and at the S1 body, it is compressing the caudal roots. And patient is having severe radiculopathy, she is unable to walk. So I discussed all the options, but she refused for the, she refused for definitive procedures like iliac fusion and other things. So I offered her endoscopic decompression and biopsy. So these are the extent of the dissection and biopsy, where you can see the extent of the dissection from vertebral body end plate to the mid part of the vertebral body. And here is the small video taking the biopsy. Sorry for the poor quality of the video. That is the root, and I am taking the biopsy from the root after root is free. So histopath shows a squamous cell carcinoma. She is relieved of their symptoms, and she was sent for the oncology center for further management. So here I am suggesting that apart from the degenerative pathology, spine endoscopy also helps in the palliative care of the spinal meds, other tumors also. So that is all. Thank you for giving me this opportunity.
Thank you so much.
And here are my special thanks to Dr. Dilip, who is my mentor in India, and his guru, Dr. Lim. And thank you.
Thank you. Nice presentation. Now, dear delegates, we are closing afternoon session. Who have any question, any interesting question, you can give to the speakers. We have time for discussion. Kimda savol bo'lsa, hurmatli qatnashuvchilar, bizda vaqt bor. Уже bittadan keyingi sessiyamizni tugatamiz. Bugungi dokladlar tugadi. Kimda savol bo'ladigan bo'lsa, qiziqarli savol bemalol speakerlarga berish mumkin. Qanaqadir tarjima qilish kerak bo'lsa, biz yordam beramiz. Kimda qanaqadir qiziqtirgan savol bo'lsa, bemalol berib speakerlarga berishimiz mumkin. Diskussiya qilish uchun bizda yetarlicha vaqt bor.
Ahror. Assalomu alaykum. Menda birinchi savolim professor Kontaktlimga. Hozir sheyni отдел bo'yicha doklad bo'ldi. Mening savolim стенозирующий лигаментит осифицированный nevrologiyasi bilan 3-4 segmentda egallagan. O'shanda nima taklif beradilar? Bu birinchi savolim.
Savolingiz o'sha posterior longitudinal ligament kalsifikatsiyasi.
Unda kalsifikatsiyada nima tavsiya beradilar? Unda ham shu metodlarni qila olinglarmi yo o'sha traditsionniy ketadimi?
Agar kompressiya old tarafdan bo'lsa nima bo'lsa, to'g'rimi?
Ha, tamom. Ikkinchi savolim, endi sherigimning savoli ular ketib qolishdi. Shu xirurgga operatsiya jarayonida mana 1 soat, 2 soat bo'ladi. O'shanda IOP ta'siri qanchalik va yiliga xirurg qancha doza oladi o'zi normada olish kerak? Ularni praktikalarda qancha oladi? Qanaqadir исследованиялар bormi shu bo'yicha?
Sir, question for you. First question, if patient has posterior longitudinal ligament calcified for 2-3 levels, I mean is because of calcified is compression, is anterior compression. What's your tactic? Your approach will be ACDF or is posterior approach?
Cervical case, right? So, as I mentioned, to check a dynamic MRI is very important to know what is the main the pathology first. So, if the patient has the anterior compression with a calcified disc, we have to anterior approach the HDF. Right? But sometimes, in case of the posterior, the calcified the ligament flavum, we have to remove the ligament flavum posterior approach. But the patient have anterior posterior 2 pathology. We have to, unfortunately, we have to posterior optic first and anterior HDF next.
Second question is, what is the radiation of serum? How much radiation usually we are taking in one day? Or like, do you know or do you have his research or note you have, or he's asking, he wants to know how much radiation we can take. His limit.
Apron. Yeah, yes. But to check the serum view, in case of the foraminal approach, just lateral serum view is enough. So most of the smart doctor trying to check AP lateral view for transplant approach, right? But we have some the way to reach the foraminal side with just lateral the shunt view. I will let you know next time. Each one of the reduce the radiation. I don't know.
Bular aytibdilar, agar bo'yinda o'sha kalsifikatlangan bo'lsa ham, kalsifikatlangan disk va anaqa OPLL deyiladi, o'sha ossification posterior ligament. Agar u kompressiya old tarafdan bo'lsa, old tomondan kirilaveradi. Agar bir vaqtda o'zida kompressiya ham oldi tarafdan ham orqa tarafdan bo'ladigan bo'lsa, uni oldidan ham dekompressiya qilish kerak, orqadan ham dekompressiya qilish. Agar faqat orqa tarafda o'zidan kompressiya va old tarafdan bo'lmasa, faqat orqa tarafda o'zidan dekompressiyasi yetadi. Radiatsiya bo'yicha men bilmayman, qancha radiatsiya qilish kerak, qanaqadir anaqa nima deydi, исследование o'tkazilganini bilmayman deyaptilar. No, eng yaxshisi o'sha anaqa rentgen protektiv xalat kiyish kerak bo'ldi.
O'sha birinchi savolda o'sha traditsionniy qilish kerak deyaptilar-da.
Traditsion emas, o'sha endoskopda kirib siz agar kalsifikatlangan disk bo'lsa ham, kalsifikatlangan o'sha ligament bo'lsa ham endoskopda kirib qilsa bo'ladi. Uni ochiq operatsiya qilish shart emas.
Shuni rasmini ko'rsatsa bo'ladimi hozir? Rasmini.
Dokladda bu?
Yo'q, hozirgi savollar rasmi bor-da, shuni ko'rsatsa bo'ladi.
Qaysi savoldi?
Hozir birinchi savolim bu.
Endi prezentatsiyadagi rasmni demoqchimisiz?
Yo'q, men hozir bergan savolni rasmi bor-da menda.
Ha, sizdanmi? Ko'rsatsangiz bo'ladi.
Bo'ladimi? So'raman.
Sir is he wants to show his MRI. MRI-mi? What's your opinion about this cases?
CT scan shows multiple 3-level the OPLL, so it shows narrow the small canal space. Yes.
Have a MRI.
Yes. How is the age?
Age? 60.
60. I think that we can try the posterior compression first. Yeah, posterior compression, the multiple level. No, it's just the first posterior compression. Yeah.
Dekompressiya qilish kerak deyaptilar orqa tarafda. Patsientni kuzatish kerak. Agar simptom hammasi o'tib ketsa, old tarafdan dekompressiya qilish shart emas.
Thank you.
Doktor Meseda Filippins. O'shanga savolim bor edi. Ularning slaydlarini ochib ko'ra olamizmi yoki ko'ra olmaymizmi?
Ochib ko'ra olamizmi demoqchimisiz?
Dokladlardagi slaydlardan savol bor edi, yo ko'ra olmaymizmi vaqtimiz yo'q?
There is a question for you. He wants to see your presentation. He has a question. That's why he wants to see one more time your presentation. It's available. Is on your laptop?
Okay.
Yeah. During this presentation, Dr. Baris is unfortunately video didn't work. Now he's working. He will show us the operation video.
Ну что, друзья, попробуем еще раз. Раз, не слышно. Здесь микрофон. Освободили память, так что будем надеяться, что сейчас все-таки получится показать ятрогенный стеноз костным цементом. Картинка не выходит туда. Сейчас? Отлично. туда надо смотреть, наверное, по ориентиру. Все, супер. Напоминаю, у нас был патологический перелом. Доктора сторонней организации выбрали метод костной вертебропластика костным цементом, выполнили, но при этом костный цемент у нас распространился в позвоночный канал, тем самым вызвал костную компрессию цементом. Здесь мы визуализировали сам костный цемент, мы пошли трансфораминальным доступом. И при помощи микрохирургических инструментов и чьей-то матери у нас получилось выполнить декомпрессию. Вот сейчас я работаю алмазной фрезой. И вот конечный результат, тот, о котором я говорил. Основную часть цемента уже устранил, остались хлопья. Сверху на 12 часов у нас освобожденный корешок. При изменении давления он флотирует. Тем самым мы понимаем, что той компрессии, которая была вызвана костным цементом, ее уже нет. Вот остатки цемента устраняем. Так, секундочку. Вот мы некоторое время назад говорили о том, что есть определенный процент рецидив грыж дисков. И я могу сказать, что на начальном этапе своей кривой обучаемости у меня был достаточно велик. Да, там порядка 5-7%. Ну, с чем это было связано? С тем, что я заходил, визуализировал сам непосредственно секвестр, устранял его, и на этом как бы операция заканчивалась. Там рекордное время, там, я помню, от разреза до шва достигал там 5 минут. Но тот процент возможных рецидивов, он меня напрягал, я стал разбираться в этой проблеме и стал больше времени тратить на ревизию позвоночного канала после пройденного оперативного лечения. То есть я имею в виду после удаления секвестра. И вот что я хотел показать. Опять же, вернулись к этой беременной девочке. Выбран был трансфораминальный доступ. Это вот самое начало операции, где выполняется коагуляция. Чтобы не задерживать ваше время, я вот перейду на 2,5 минуты операции. Вот видите, перед нами секвестр, мы его удаляем, у нас уже есть какая-то флотация. Но основной секвестр был удален порядка 3,5 минут. А если посмотреть, то сама операция, она была более продолжительной, да, и длилась там в конечном итоге около 43 минут. На что я потратил время, какую картинку получил я в конечном итоге. И если мы будем такие картинки получать, то возможны рецидивы или то, что мы не нашли в позвоночном канале, этих моментов будет гораздо меньше. Сейчас покажу. Хочу обратить внимание, что в диск я не захожу. То есть вообще понимание того, что формирование доступа через диск, у меня в голове не укладывается. То есть я выполняю декомпрессию и называю эту операцию не эндоскопической микродискоэктомией, а эндоскопической декомпрессией позвоночного канала. То есть я не перфорирую дополнительно фиброзное кольцо. Тем самым я создаю благоприятных условий для последующих рецидивов. В данном случае меня не устроил еще остеофит с нижней замыкательной пластины выше лежащего позвонка, поэтому я решил выполнить здесь еще и костную декомпрессию. Потом на этом я не ограничился, я пошел и еще больше резицировал латеральный край фасеточного сустава. Видите, перед нами уже открывается манжета проходящего корешка. И вот конечная картинка, то, к чему надо стремиться при выполнении трансфероминального доступа, картинка должна быть вот такая. То есть у нас есть на протяжении выделенный корешок, у нас нет повреждения фиброзного кольца и нету никакой костной компрессии. Это все у нас, в принципе, это получилось сделать из трансфероминального доступа. Видите, на всем протяжении корешок у нас освобожден. Спасибо, коллеги. Это, в принципе, все, что я хотел показать сегодня. Если будет интересно, завтра покажу возможные осложнения и как их избежать. У меня тоже это запротоколировано. Спасибо.
Спасибо вам большое за выделенное время. Если нет вопросов... Есть ли еще вопросы к лекторам?
Okay. Именно unaqa patologiyasi hozir yo'q ekan, men uni bilaman deyaptilar. Просто prezentatsiya bo'lmagani uchun og'iz aka javob berishi mumkin deyaptilar. Savolingizni bering, qolganlar ham eshitsin. Savolingizni qilib bering, qolganlar ham eshitsin, o'shanga javob beradi.
Ko'rsatalarmi ekranda? Hurmatli hamkasblar, bu doktorimiz Filippinlik Meseda degan doktorimizni dokladida bitta narsaga e'tibor berdim. O'sha e'tibor berilgan holatga savol berdim. Agar kim qiziqayotgan bo'lsa, ahamiyat berishingiz mumkin. Umurtqa pog'onasini birinchi bo'yin umurtqasini orqa задний продольный связкасida ko'pincha uchraydigan patologiya bor. Bu patologiya ossifikatga o'xshagan, lekin ossifitsirованный emas, воспалительный, дегенерированный, утолщение задней продольной связки, o'sha birinchi sheyniy va ikkinchi sheyniyni chegarasida. Mana hozir ko'rib turganimizdek, bularni slaydlarida, pусть он откроет слайд. Желтый связкani gipertrofiyasi bor orqa tomonda va oldi tomonda o'sha aytayotgan holat bor, spinnoy mozgga ezilishi. Желтый связкani gipertrofiyasini hisobga olmaganimizda mana strelkada ko'rsatilayotgan patologiya bor. Meseda vrach bu bilan shug'ullangan ekanlar. Bularga shu savolni berdimki, mana shu holat qanaqa tashxis qo'yiladi? Nima deb diagnoz qo'yamiz mana shunaqa holatda? Ahrar, это первый вопрос.
The diagnosis.
Bir beramizmi yoki to'rttala savolni beraveraymi?
Men to'rttala savolni berib bo'ldim o'sha.
My diagnosis for these cases is pannus formation from arthritis. All right. Now, your question is, what if there is no C1-2 ligament hypertrophy, right? So if it's only pannus formation, then you cannot do posterior decompression. Anyways, my indication for spinal cord decompression is number one, if the spinal cord is compressed. If the spinal cord is not compressed, even there is panus formation, then there's no need for surgery. Only problem is if there is instability. If there is instability, then you have to do occipito-cervical fusion. But in this case, it's already fused. There's autofusion, so there's no need for occipito-cervical fusion. Just a plain decompression will do. If your question, I think it's common nowadays that we can see panus formation from arthritis. What to do? Dr. Im, in his lecture, Dr. Lim Kangtek, had a lecture earlier about panus formation, endoscopic removal of panus formation. Maybe you can show that again. So this patient is not a good example for your question, but the diagnosis is panus formation from arthritis. Rheumatoid arthritis or even osteoarthritis can develop panus formation.
Diagnosis panus formation nima hisobida kelib chiqadi? Reumatoidni artriti bor bemorlarda bo'lishi mumkin yoki bo'lmasa o'sha o'zida so'stavda o'zida osteoartroz bo'lsa o'shani hisobida kelib chiqishi mumkin. Ya'ni suyakda deformatsiya bo'ladi, deyapti. Deformatsiya bo'lgani hisobida orqa miyani siqishi mumkin. Agar orqa miyani siqadigan bo'lsa, unda ikki xil taktika qilinadi. Dinamik renginda agar u fiksatsiya bo'lib ketgan bo'lsa, oldi tarafdan bosib turib dekompressiya qilsa bo'ladi. Agar dinamik renginda уже nestabilniy bo'ladigan bo'lsa, unda sheyni oksipitalni fiksatsiya qilish kerak edi. Agar aniq fusion bo'lib ketgan bo'lsa, ya'ni o'zi tabiiy fiksatsiya bo'lib ketgan bo'lsa, oldi tarafdan kirib dekompressiya qilsa bo'ladi. Agar dinamik renginda уже nestabilniy bo'lsa, uni qilish kerak emas, faqat orqa tarafdan qilib sheyni oksipitalni fiksatsiya qilish kerak.
Bu holatda o'sha bemorlarda nevrologik o'zgarishlar yoki bo'lmasa oddiy og'riqli sindromlar ham bo'ladimi, bo'lmaydimi?
Agar
uchratganmi, uchratmaganmi praktikasida?
What kind of symptoms patient is having if there is compression?
It's always myelopathy symptoms. If the panus formation is causing compression, it's always myelopathy symptoms. Wide base gait, that's number one. Number two is weakness, and you can have DTRs, +3 DTRs, hyper reactive DTRs, Babinski, ankylosing, and you always have to ask if they have a problem with erection, if it's male, or bowel and voiding in female.
Symptoms qanaqa bo'ladi? Birinchi o'rinda yurishida paxotkasida o'zgaradi. Agar u yoqda orqa miyani siqib turgan bo'lsa, deyaptilar, myelopatiya boshlangan bo'lsa. Ikkinchisi motorni weakness, ya'ni oyoqda kuch kamayib ketadi, qo'l oyoqda. Uchinchisi, agar u erkak kishi bo'ladigan bo'lsa, ereksiyasini so'rashingiz kerak, deyapti. Ereksiya qanaqa pasayib ketdimi, yo'qmi? Nimasi reflekslari kuchayib ketadi.
Stabilniy holat bo'ladigan bo'lsa, zadnim dostupim endoskopический kirib o'sha yerda o'zini tozalab qilish mumkinmi?
Mumkin. Uni aytibdi, agar stabilniy bo'lsa, kirib qilsa bo'ladi. Nestabilniy bo'lsa, uni sheyni oksipitalni fiksatsiya qilish kerak. Thank you, Dr. Yujan. Dear delegates, so today we are finishing our day. Now is, if you don't have any question, we have time because dinner is at 7. we can discuss, or who wants to take rest, you can take rest till the dinner. Dinner 7:30 or 7 p.m. Yeah. No, the dinner is 6. Be ready 6.